the second.
Dr. Vibhushan,
Ma'am.
I'll just initiate. Okay.
Yeah.
Good afternoon, everyone. It's my privilege and pleasure to initiate this second day of the program of Gurukul, which is definitely programmed and designed for the benefit of the exam-going PGs. See, we have made this program in such a way so that the PGs not only have the case presentations, but they also get the benefit of discussing with the senior teachers the points regarding the contraception, CTG, specimen, drugs, and as well as dummy pelvis, breech presentation, etc. I'm sure yesterday all the PGs had a nice interactive session with the senior teachers, and they have really gained from yesterday's scientific program. We also look forward for next 2 days of scientific program, and I'm sure all of our PGs will really benefit, especially from exam-going PGs will really benefit from these 2 days program. It's my pleasure and privilege to invite Dr. Chandra Mansukhani, who is the president of the ISOPARB Delhi chapter. This program has been organized by Institute of Obs and Gynae, Sir Ganga Hospital under the Aegis of ISOPARB Delhi chapter. So it's my pleasure to invite our president, Dr. Chandra Mansukhani, who is the president of ISOPARB Delhi chapter, to say a few words. Dr. Chandra is a senior consultant, Institute of Obs and Gynae, and she is the president of ISOPARB Delhi chapter, very much active in teaching the students, and she has always taken a great interest in all the academic activities of the department. Over to you, Dr. Chandra, for your pearls of wisdom.
Yeah, thank you, Dr. Mala, for your kind introduction. And first of all, good morning, everyone. On the behalf of ISOPARB Delhi chapter, I welcome you all on the second day of Gurukul classes. I welcome all eminent speakers, teachers, and moderators for their great effort for making our students to learn basics and important points for final examination. I welcome all students also who have participated in large number to make these classes great success. They are getting opportunity to interact with great teachers on one-to-one basis and clearing their doubts without fear. Because in exam, they are always under fear and they cannot talk up to that level. Here, they are without fear and they can ask any question to any teacher. Once again, I welcome you all and hope all the students will be benefited from today's learning and discussion on the important topics which Dr. Mala has decided, and she has chosen very good topics. So thank you and welcome again everyone here for this second day of Gurukul classes.
Thanks, Dr. Chandra, for your words of encouragement, and I'm sure all the PGs will really benefit for these programs that we have designed and programmed so well. Now I invite Dr. Vibhushan, who is a fellow in the department unit of gynae oncology at Sir Ganga Hospital. Sir is a senior person. He is a colonel from Nepal Army, and we are so happy to have Dr. Vibhushan with us as a fellow for the last 1 year. Over to you, Dr. Vibhushan, for your conducting the scientific program of the day. I also welcome Dr. Gujral. Madam has joined us. Madam is the chairperson, Institute of Obs and Gynae, Sir Ganga Hospital. And Madam, we are always very happy to have you with us because you always encourage us in all the academic activities of the department and all the programs that we make. You always give very important inputs. Over to you, Dr. Vibhushan, to carry on the scientific program, and we can carry on today's program without delay. Over to you, Dr. Vibhushan.
Thank you, ma'am. Now, without further delay, we are going to start our session. The next session will be discussed on multiple pregnancy, moderated by Madam Gujral and Dr. Chanchal. Slide, please. Ma'am is a lead consultant fetal medicine in Madhukar Rainbow Children's Hospital and Birthright by Rainbow Hospitals, and current member and past chairperson of AOGD Fetal Medicine and Genetics Subcommittee. The presenter for the program are Dr. Nikita Sarma, DNB trainee, and Dr. Vasundhara. She is also primary DNB second year DNB trainee. Over to our presenters for the case presentation.
Chanchal, are you there? Has Dr. Chanchal logged in?
Not yet, ma'am. Not yet.
Not yet. So we wait for her. Any idea when she's going to log in? Do we start? Vinod, can you give him give her a ring?
Yes, ma'am. I'm doing.
Madam, you start.
Just so that
I check from Dr. Chanchal.
we just start. I thought if she's just taking a second or so, we just wait for it. Just for a second. Let's see. Who's gonna give her a ring? Presenters, are you ready? Why are we? You are ready, Vasundhara and Nikita?
Yes, ma'am.
And who's going to present? Who's going to take up the discussion?
Ma'am, we both are going to present.
Be loud. Sorry.
I will be presenting history and Nikita is presenting examination.
Okay, so both of you are collectively presenting the case. Fine. So, Vinod, do I wait for Dr. Chanchal? Yes or no?
Ma'am, you can start.
Hello? We'll start. Huh? Just give her a ring. Tell her I'm waiting. Right.
Okay, ma'am.
Oh, Vasundhara, start off with your case.
A very good afternoon, ma'am.
Louder, closer to the mic. Thoda close ho jao, mic.
To you all, I will be starting with my case presentation of twin pregnancy. 1 second, ma'am. The slides are not changing.
Doctor, so
Dr. Chanchal is joining.
Resident of
Dr.
Gurukul.
Chanchal is joining.
Chanchal is joining. Very fine.
Yes.
Very good. Just wait for it.
Standard
Fine.
wife of
But,
Mr. Y, labor by occupation belonging to lower socio.
No, wait.
Dr.
Can we
Chanchal
have
is
a
joining.
voice
I had a word with her. She's joining.
Chanchal is joining fine. Mala, we are not having voice clarity. So see what's wrong somewhere.
Okay. This Mr. Vinod will see.
Mrs. X, 28 years, resident of Burari, homemaker, educated up to 10th standard, wife of Mr. Y, laborer by occupation belonging to lower socioeconomic status by modified Kopuswamy, primary gravida with 34 plus 3 weeks of pregnancy with LMP of 23/9/2022 and estimated date of delivery by Negli's formula 30/6/2023. She was referred to us in view of twin pregnancy and was admitted for evaluation and for safe confinement. History of present pregnancy. Her pregnancy was a natural conception, was diagnosed with a UPT at 1 week overdue, and ultrasound was done in which she was told that she has twin pregnancy with 2 different placenta. She gave us the history that the ultrasonologist told her दो अवल नाल हैं और दो अवल नाल है दो बच्चे हैं. Folic acid supplementation was taken. Baseline investigations were normal as per the patient. No, we were not able to have any data. History of excessive vomiting at 2 months and was admitted at outside hospital and was treated with IV fluids and injectable medicines for vomiting. No history of fever with rash, burning micturition, bleeding per vaginum or spotting per vaginum. Abnormal vaginal discharge, drug or radiation exposure. The number of ANC visits as per the patient during the first trimester were 2. There was no weight gain as per the patient. In second trimester, quickening was felt at 5th month of pregnancy. Level 2 scan was done and was normal as per the patient. Test for diabetes was done and it was normal. 2 doses of tetanus were taken. Iron, folic acid and calcium tablets were taken regularly. History of spotting per vaginum was present in 5th month. She took weekly injections for 3 weeks, likely progesterone. ANC visits were 3. Weight gain was 5 kg. In third trimester, perception of adequate fetal movements were present. History of iron and calcium intake were present. No history of any bleeding per vaginum or spotting per vaginum. The total ANC visits were 2. Weight gain was 6 kg. She had some abdominal discomfort and she came to our hospital for evaluation and safe confinement. She was evaluated and she was hospitalized, evaluated and discharged after 24 hours. Her menstrual history, she attained menarche at 14 years of age. Her past menstrual cycle were for 4 to 5 days, 28 days cycle regular with average flow. No history of significant dysmenorrhea was present. Marital history, she is married since 1.5 years, non-consanguineous, monogamous marriage, obstetric index, she is a primary gravida, cohabiting with husband since marriage. There is no history of any contraception use. Past history, no significant medical history was present, no significant surgical, no significant drug history or any known allergy history was present. Personal history, she has normal bowel and bladder habits, normal sleep-wake pattern, normal appetite, no adverse social habits. On the basis of 24 hours recall method, her daily calorie intake was 2,450 kilocalorie and her daily protein intake was 56 grams. Family history, her father is known case of diabetes since 20 years on treatment, no history of twin gestation or twin pregnancy in family as per the patient. Socioeconomic history, husband is 10th pass, working as a laborer belonging to lower socioeconomic status according to modified Kuppuswamy scale. Good afternoon, everyone. I'm Dr. Nikita. I'll be presenting general examination. Patient is conscious, alert, and oriented to time, place, and person. She is averagely built and looks well nourished. Her height was 158 centimeter. Pre-pregnancy weight was 54 kg. And BMI was 21.6 kg per meter square, which is normal. Current weight is 65 kg and total weight gain during pregnancy is 11 kgs. On head-to-toe examination, there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. On breast examination, no abnormality was detected. Thyroid was normal, no enlargement was there. Tongue, teeth, gums were normal. Spine, there was she had a prominent lordotic curvature and she had a waddling gait. Her vitals are respiratory rate is 16 per minute, regular abdominothoracic, BP 120 by 80 mmHg in both arms in sitting position. Pulse is 82 per minute, regular with good volume. All peripheral pulses were felt. No radioradial or radiofemoral delay was present. Temperature, she was afebrile to touch in 97.6 Fahrenheit. Her CVS examination was not, S1, S2 is normal. There were no murmurs that were heard. Respiratory is normal, bilateral air entry equal, and CNS no focal neurological deficit present. Obstetric examination. On inspection, abdomen looked over-distended, flanks were full, umbilicus is midline everted, linea nigra and stria gravidarum were present. There was no scar, no sinus, no dilated veins. All quadrants were moving equally with respiration. All hernia sites appeared normal. On palpation, fundal height corresponds to 36 weeks of gestation. Flanks were full. Symphysis fundal height was 36 centimeter. Abdominal girth was 42 inches. On fundal grip, hard ballotable part was felt at fundus, likely to be the head of the fetus. On lateral grips, multiple fetal parts were palpated on both sides. On first pelvic grip, round, hard, ballotable fetal part felt, probably fetal head. On second pelvic grip, findings of the first pelvic grip were confirmed. Cephalic pole was not engaged. On auscultation, one FHS was heard in left spino-umbilical line, rate 140 per minute in regular rhythm. Second FHS was heard on right side above umbilicus, rate 155 per minute, regular rhythm. On local examination, external genitalia appeared normal, no leaking PV or bleeding PV present. Case summary. Mrs. X, 28 years of age, primary gravida at 34 plus 3 weeks of gestation, LMP September 2022, EDD 36-2023, has been admitted for evaluation and safe confinement. She is perceiving normal fetal movements and there is no history of labor pain or leaking PV. On examination, there is no pallor or pedal edema. Her BP is 120/80 millimeter of mercury. Obstetric examination reveals twin-like fetuses with presenting twin S cephalic. Liker appears average. Uterus is relaxed, and FHR in twin 1 is 140 BPM heard in left spino-umbilical line, and FHR in twin 2 is 155 beats per minute heard on right side above umbilicus.
So where are you people logged in from? Your voice was unclear. Now, Chanchal, you've been able to read. I guess you've not been able to hear all. Is that okay?
Yes, ma'am.
Can you hear me, Chanchal?
Good afternoon, ma'am. Yes, I was able to hear.
Good
also.
afternoon. Good to see you. We read the history. We couldn't hear that properly. So now let me start. You said she was admitted for evaluation and she had her AMCs outside, right? And you're going by her history saying that she's a dated pregnancy and she's a dichorionic as per the patient's thing that the oval say. Now, if you were to see her for the first time now, see her records, how would you calculate her dating? She said she has regular periods, she has confirmed pregnancy test. Based on the ultrasound, how will you check on her dates?
We will take the CRL of the larger twin to date the pregnancy.
Why do you want to take the larger? Why do you spare the smaller one?
Ma'am, pathological larger twin is not possible in the first trimester, but smaller twin can be possible.
Smaller twin can be?
Can be possible, but pathological larger twin is not biologically possible in first trimester.
Well, growth restriction later, where you will not be able to diagnose. And how to do chorionicity? Just quickly enumerate the signs, and then we go further.
Ma'am, we will go for an early scan in which we will go for 2 gestational sacs. The 2 placental masses can also depict the chorionicity. There are twin peak sign and T sign. Twin peak sign in which the intertwining membrane is more than 2 millimeters. There are 4 membranes present, because of which placental tissue is projecting inside the membranes. That's why there is a lambda sign or twin peak sign. Then if the projecting membrane is placental tissue is not projecting between the membranes, as in monochorionic, then there will be a T sign. And sex, and based on the sex also. That is the definite sign of dichorionic diamniotic twins.
Right. I think you read your twins well. Chanchal, you got to say anything on that? She said the signs all right.
Yes.
Yeah. So now we agree that to determine the chorionicity. How do you label the twins? 4 coming after coming? How do you label the?
No, ma'am, upper or lower.
Why? You say no, justify.
Ma'am, twin, they are growing.
You're right in your answer. Why do you label? How do you label them? Let's see that.
Ma'am, we label them as either left and right or upper or lower, based on the lie of the membranes in relation to the longitudinal axis.
What does
But how
make a difference?
how is which is the presenting twin and which is the aftercoming twin?
Ma'am, at the time of a scan, we will go for a same plane, we're having 2 fetal heads or 3 poles at the same plane, same time. Labeling. Then, ma'am, we will go for right and left depending on the fetal head. No? Ma'am, it is either upper or lower or left or right, depending on the location of the membrane in relation to longitudinal axis. If it is in parallel to the longitudinal axis, we label them as left and right. And if the dividing membrane, the membrane is in horizontal axis to the longitudinal axis, then upper and lower.
Can't hear you. Central, just unmute yourself. Can't hear you. You can see your lips moving.
So the labeling, labeling is an extremely important part of the first trimester assessment.
Yes.
Because in case they're concordant twins and one has, suppose, a cardiac anomaly which needs assessment postnatally. So unless you're sure which fetus is which, one would not be able to assess so quick that which is the twin which needs immediate resuscitation. So the fetus which is to the internal should be labeled as in one, and it should be clearly documented in the notes. And as the baby grows, in the initial part of the pregnancy, they can be up or lower. But as they grow, they have a tendency to align themselves side by side. So one must always ensure, otherwise, when you scan them consecutively, there's something called yo-yoing of growth, wherein because of the incorrect labeling, you are comparing one growth with the other growth of the other when you see the patient next. So labeling is extremely important. The twin,
So,
which is closest
yeah.
to the loss, left, upper, lower, gender, we don't really reveal, but one can always put a note.
Yes.
Which is accessible only to yourself.
Yes, for your records, you can put it that you looked at the one gender fetus and you're watching that one, and don't make a mistake like that. Did you understand the answer, Nikita?
Yes, ma'am.
This is what I want is on your behalf, Dr. Chanchala's answer. All right. So first semester you gotten done. Now, what else are you going to do at the first semester for this patient? If you had looked after from the beginning, you have
Aneuploidy
what is the next step?
Aneuploidy screening.
How do you do that?
Ma'am, we will take, if it is dichorionic diamniotic twin, we will take NT of the individual twins, and we will take the mean of the serum markers, beta HCG and PAPA. And then we will put the formula for determining the risk. And if it's a monochorionic, then we will take the mean of the NT and mean of the serum markers. The detection rate is usually lower than singleton pregnancy, ma'am. And if there is a case of vanishing twin and there is a measurable pole, then we can take the NT and the maternal age for the aneuploidy screening. We can consider. We will
Yeah, then you don't take the serum analytes because that one also may produce something, correct. And how about NIPT?
Ma'am, NIPT has also a detection rate lower to the singletons, but because of advances like single nucleotide polymorphism techniques and all, we can go for an. Just remember, detection rates will be lower than that in singleton.
So currently, the NIPT, see, in monozygotic twins, in genetic material, so the detection rate should be as good as a singleton. And that is
correct, absolutely.
Even in dichorionic twins, most of the current literature says that it is in line with the singleton.
Yes, ma'am.
Yeah, SNP technology will do it, but as maybe
Yes.
more technology is required. But as of now, we are near par, if not the same.
Yes. Yes.
Right.
Yes.
Now, which one of you will enumerate maternal risks in a twin pregnancy and fetal risks? One of you say the maternal and one of you say the fetal. Then we go one by one.
I will say the maternal risks.
Bolo.
During antenatal period, she has, because twin pregnancy, the physiological adaptations are exaggerated. So she has more nausea, vomiting. She has more cardiorespiratory distress, more risk of anemia, more risk of hypertension, gestational diabetes, and more risk of antepartum hemorrhage. And ma'am, there are mechanical distress of the uterus, ma'am. Because of that, there are risk of ma'am, there is risk of varicose veins or excessive swelling in the legs due to compression from the gravid uterus, and there may be obstructive uropathy also.
That's really not I mean, this is a part of the physiology, but we agree with your hyperemesis. We agree with hypertension.
Preterm labor and premature rupture of membrane, as well as
Preterm labor, that's the most important.
There can be risk of postpartum hemorrhage also. There are chances of
Right.
hemorrhage also, ma'am. And polyhydramnios.
And what?
Ma'am, obstructive uropathy can be also. And during labor, there might be early rupture of membrane. There is risk of prolapse and difficulty in delivery due
So
to
the prematurity related risks that come on the fetus also got. Chalo. And fetal risks?
Ma'am, there can be chances of spontaneous abortion, which is more common in monozygotic twins. there are chances of fetal growth restriction. There can be discordant growth. It can be found in both dizygotic as well as monozygotic. There can be prematurity, ma'am. Because of prematurity, there can be fetal risk of respiratory distress syndrome and necrotizing enterocolitis, intraventricular hemorrhage, prolonged and ICU stay, need for ventilatory support, and all. Hypothermia, hyperbilirubinemia, which are the risk of prematurity. Then there can be chances of congenital anomaly, which is more common in monochorionic twins. There are chances of intrauterine death of the fetus. Ma'am, in the monochorionic twins, there can be chances of twin-to-twin transfusion syndrome, twin anemia, polycythemia syndrome, acardiac twins.
So these are unique complications to the twins, no? We just
Yes,
said
ma'am. Yes,
complications. I think she said all. Has she missed anything, Dr. Chanchal?
No, ma'am, sorry.
She said all. And normally should have come before the preterm, no? So if you think like a student enough for abortion, then what? Anomaly. Chromosomal anomalies are not higher, but structure anomalies. Then comes your, preterm birth, growth restriction, and so on and so forth. This is the way to go. All right. So now in your case, what risks do you think she's had in this pregnancy? In your case, enumerated the complications in your history. What has this patient had?
Ma'am, she had abdominal discomfort at 34 weeks of gestation. Before it is an uncomplicated.
No, you missed something. You wrote in the history. Only one thing you wrote in the history, and you not remember that.
Spotting.
Sorry.
Spotting.
Sorry.
Ma'am, she had
Sorry.
in first trimester she had excessive vomiting.
Yeah, so she had hyperemesis. No, that's a complication which can come, hyperemesis, right? So you should have started since she was hospitalized. That's the only time she was hospitalized.
Yes,
When you say she had discomfort and admitted at your place, what would have you done for her? These are the technical questions we asked you, chronicity, etc. But in your case, when she had discomfort, that's why she came to you, and then she thought she'll register here for delivery. So what would have you done? What is this discomfort? How would have you have evaluated this discomfort?
Ma'am, first we will rule out any chance of preterm labor or anything. She came with discomfort, and then any contractions or any preterm labor, we will rule out it. And in multipetal pregnancy, there is increased cardiorespiratory distress also. But she came with
No, so you did not elaborate on the discomfort. No, what I meant that your patient one complaint, discomfort. So where was the discomfort? Was it walking, swollen legs? What is abdominal? What is
she was having abdominal discomfort when she
right? So
she was 34
abdominal
weeks.
discomfort. How would you evaluate in a twin pregnancy, 33 weeks? What she comes to you? What would
we will firstly ask her the history, ma'am, about the abdominal discomfort. Whether she is having any pain, whether there is tightening, intermittent tightening, whether there is any localized pain, whether there is frequency of, because she is primigravida also. We will ask her about any leaking. Sometimes the primary gravidas are confused about leaking and frequency of micturition. The frequency of micturition can point towards, ma'am, urinary tract infection, which might be not common at 34 weeks, but still we will consider it as a DD. Then we will, ma'am, firstly do the uterine contraction assessment. We will check for any uterine irritability. If also, ma'am, we will rule out any
go on.
In vomiting or loose motions or any gastrointestinal symptoms.
I was waiting for her to say that. I don't know if Chanchal pointed out, you remembered. Huh? Commonest cause of discomfort is GI upset. No, you didn't write any loose motions, anything like that. Even a constipation can give rise to abdominal discomfort in pregnancy. Then you come to the thing, all right, you were assessing her uterine contractions. What else would have you assessed to be sure that she's not in preterm labor or a threatened preterm, whatever? Sorry, be loud, please. Voice is so cracking.
Can't hear you.
Ma'am, firstly, we could have done an abdominal assessment. Then after that, we could.
You already done abdominal assessment. No, you already said you'll. What is a local examination?
Ma'am, for any leaking or dripping. And then PS and PV, ma'am. PV, ma'am.
Yahi to na.
With
The
analysis.
only thing you want, how would you know that the patient is in labor? Leaking aapne dekh liya, not there. Cervical assessment has to be done, no?
Yes,
Huh?
ma'am.
If it's already dilated open cervix, you better be careful in admitting her, right?
Yes,
No?
ma'am. Yes, ma'am.
That part was missing. All right. What else will you do now? Your case, let me finish your case. Hyperemesis, you said. Discomfort, we said. What else would you now do for your case?
Ma'am, after ruling out everything, we will then, we are admitting her, then we will run the basic tests.
What will you do?
Ma'am, we will monitor the fetal heart rate and the maternal condition while she is admitted, and after ruling out, we will go for an ultrasound for.
Exactly. That is what you should have done. No, you don't have any one of her ultrasounds. You have only the history that all is well and okay with her as per the patient. She's come to at 33 weeks. I mean, you don't know the weight discordance, etc. Anything, you know. So you should have done one ultrasound at this particular stage to know whether the fetuses are AGA, SGA, discordant, you know, and even the presentation like her and everything. Correct? No?
Yes, ma'am.
And something else I would recommend in this trimester right here.
Ma'am,
Bolo?
CBC, ma'am, we will,
Sorry?
ma'am, ultrasound and, ma'am, we will see.
Ultrasound to ho gaya na? Ultrasound to.
For CBC also. Anemia is more, anemia, there is high risk of anemia. Any baseline investigation of the patient, we are not even sure about the Rh positivity or negativity of the patient. So we will run out all the basic investigations. The OGTT status as per the patient is known. She is saying, but we don't have any data or documents at present.
So you'll do all the routine investigations because you don't have the investigations, right? No. What is so special in this case, which should be evaluated, even if she gave you a hemoglobin, etc., report? What is so special in this case, which should have been repeated in third trimester? A very strong history of family history of diabetes. Her father was diabetic, right? She just said her sugars were normal, right? And even were normal in the second trimester at 24, 28 weeks, twin itself is there. You should have evaluated her sugar screen once again, whichever method you follow in your hospital. 75 grams.
People are saying that in baseline investigations.
Sorry?
Yes, ma'am, we will.
Yeah, she gave an early, all verbal report that her sugars are normal, everything was normal, right? But in this case, her father is a diabetic for 20 years, you said in the history.
Yes, ma'am.
History is strong. So you should evaluate her. That's all about it. Okay. Dr. Chanchal, ask us something. Screening hypertension. How is it different from the singletons?
Ma'am, in dichorionic diamniotic, the number of visits are 8 only, but we will have to involve 2 specialists, and the 4 weekly ultrasound should be done for serial growth monitoring.
मैं तो hypertension की बात कर रही हूँ. I'm not talking about serial growth. Twin, you said complication of hypertension, no? Maternal. What will you do for that?
Ma'am, we will do screening of preeclampsia, and if there is any one risk factor beside twin itself is a risk factor. Beside twin, if there is any other risk factor present, we will start aspirin, ecosprin.
Say you should regularly monitor her blood pressure. More than that aspirin you would have given or not given now. If she's not taken it, you can't give her aspirin now. It has no meaning.
We can't give it.
You'll be vigilant to be on the guard for hypertension, because this is a complication can happen in twins, right?
Yes.
Whether you screened her at, you didn't get the patient in the first trimester, so how would you have done that? Right.
So she's been.
Rachanchal, ask us something. Malformations, that's your area.
And so this is a DCD twin pregnancy, 34-weeker, which came to you with abdominal discomfort. So the question here is she in preterm labor or not? which by all your examinations and you've assessed the cervix and you feel she is not in preterm labor. Is there any role of prophylactic steroids here in a twin pregnancy at 34 weeks?
No, ma'am.
Right. So can you elaborate on that a little bit? That nowadays we are discouraging.
No.
Yes, ma'am. Ma'am, beyond 34 weeks, we do not use steroids as
Absolutely.
the risks outweigh the advantages.
Right, right.
Cognitive impact.
Right. And the second question is, when you ask for an ultrasound, would a growth scan suffice, or would you want what additional information when you fill up that form? What in addition would you want to know?
Ma'am, growth scan plus Dopplers.
Yes. So Dopplers must be included as part of the ultrasound assessment in a twin pregnancy. The third question, which ma'am was pointing out, that because you said twins you get double of everything, double the amount of hypertension, double the amount of diabetes, and double the amount of mechanical discomfort. So BP monitoring, you would advise a home BP monitoring. How frequently are you going to review this patient? And what all assessment does one do apart from what you've already told about examination? When she comes back to you, what will you assess in the clinic?
Ma'am, we will look for BP and weight, and then we will look for per abdominal examination, any signs of anemia, pallor, icterus, or anything, and in case of hypertension, any pre-monitoring. Yes, ma'am. But we are when she comes to visit us at clinic, we are seeing her BP. If it is in normal range, then it is okay.
So urine routine.
For abdominal
Absolutely.
examination,
Simplistic
signs of
a urine routine.
Yes, ma'am.
A urine routine
It has to be
examination,
done
a
at
urine
every
dip-
visit. Urine dipstick has to be
At the routine, a urine dipstick is a very efficient of
Yeah,
looking
not
for
in it.
all the complications that
Yeah.
we are discussing.
Right. Nikita and Vasundhara, tell me any particular guidelines for seeing the malformation? Any particular guideline? How much time should be spent on the malformation?
For the anomaly scan, as compared to singleton, it is done in later stages, later weeks of gestation, and we have to spend 45 minutes. 45 minutes.
45. You're looking at 2 fetuses now, so the recommendation is 40 minutes for a structure anomaly check. And how much time for growth check?
Ma'am, 30 minutes.
30 minutes for growth. And it will check the growth of both the babies.
Both the babies.
The growth, how do you check the growth, so-called? What are the parameters you use for growth?
Ma'am, we use abdominal circumference. We used by Hadlock's formula.
Sorry, abdominal circumference?
Estimated fetal. In the estimated fetal, here we use.
How do you determine the estimated fetal weight? Which
By
formula you use?
Hadlock's
Sorry?
formula. Hadlock's formula, which includes abdominal circumference.
2 or more parameters than Hadlock's formula determine the weight. So what is a selective fetal growth restriction if this baby has?
Ma'am, one baby has a normal growth. The other baby has a fetal growth.
What is normal growth for you?
Ma'am, the affected fetus is less than 10 centile on the growth.
That's abnormal growth. Na? That's ulta bol rahe ho?
Normal
Centile, na?
Normal fetus is not.
क्या बोल रहे हैं समझ नहीं आया.
Ma'am, the growth retarded fetus is less than 10 centile of the growth for that gestational age. And the other fetus is normal, between 10 to 90 centile.
Are there any defined criteria for selective fetal growth restriction, SFGR? Is there a name to it? Two authorities define it slightly differently. Have you read or not read?
Bol
You are near it, bolo.
Delphi consensus.
So
you're
what is
right.
Delphi criteria for SFGR? Dr. Chanchal will know more than anybody.
Effective fetal weight less than 10 percentile.
Along with It is not just the weight because
umbilical artery greater than 90th percentile or absent flows.
sorry,
No, no, not absent.
Absent, no, greater than 90th percentile.
sorry.
Umbilical artery PI greater than 95th percentile.
So an
More
estimate-
than.
Yes, ma'am. Greater than.
So percentile is a growth restriction. Umbilical PI more than 90 percentile, weight less than 10 percentile, and what else?
Abdominal circumference. Yeah.
नहीं वो तो weight में आ गया ना.
Uterine.
You don't.
CPR
Yes,
less
you
than
dis-
one.
हाँ.
CPR
What about
less
the? Sorry.
than cerebroplacental ratio less than 1.
No, no, no CPR here, please. No CPR here. We are defining selective fetal growth restriction, and we said less than 10 third centile is a growth restriction, irrespective of the Doppler flow. Then the other criteria are umbilical artery Doppler of the affected fetus more than 95th, the weight of the affected fetus less than 10 centile, discordance. Discordance, yeah, more than 20%, you know.
More than
20%. Yeah. So in monocoherent, you add the AC also instead of the weight.
Yeah.
This was, and what was the other classification? ISOG, Chanchal will elaborate on that.
Yeah, it's what you've said, ma'am. So there is one thing to understand, that discordant growth does not always mean selective fetal growth restriction.
Yes, that is
So
what I wanted them to.
Yes. So the twins, they will be of different weight unless the discordance is more than 25%. Some
Yeah, 20 or 25, whichever way you want to take it.
And then you refer to fetal medicine and you incorporate the doctor in order to interpret it. So just the estimated fetal weight or just a mere discordance is not. One of the fetuses should be less than the 10th centile, because suppose one is
Yeah.
going on the 80th centile and one is going on the 40th centile. Dopplers are okay and the fluid is okay.
Then you'd leave. Correct, absolutely.
So
That's a matter they must understand. Okay, correct, absolutely. Now tell me, what is the recommendation of number of antenatal examinations by the Royal College and dichorionic and monochorionic?
For dichorionic, it is 8. Numbers should be 8. And for monochorionic, there should be 11 ANC visits.
11, 2 with specialist on either side.
Specialist and 4 weekly ultrasound, and for monochorionic, 2 specialists and 2 weekly.
Did she say 2 weekly or did she, what did you say?
For monochorionic.
2 weekly and 4 weekly for the.
Dichorionic 4 weekly.
Right. So we are finishing with your normal twins now. Then we'll ask you the complications. We still have time. What is the recommendation on timing of birth? We said we said check of the BP. Chanchal has highlighted albuminuria as well. And how would you? What is the recommendation on timing of birth?
Ma'am, for dichorionic,
Case we talk.
delivered at 37, and for
Sorry?
monochorionic, for
No, we talk about first finish the dichorionic.
uncomplicated dichorionic diamniotic twins, as per RCOG, it is 37 weeks. And for
Sorry, as per RCOG is what?
it's 37 plus 0 to 37 plus 6 weeks, ma'am.
That is what. ठीक है.
For
And-
uncomplicated monochorionic, as per RCOG, is 36 to 36 plus 6 weeks.
And more.
And for
Monoamniotic.
monoamniotic, it is between 32 to 34 weeks, as per ACOG and NICE.
Fine. So basically by 38 weeks, uncomplicated twins, one day here or there. Now, suppose your patient does not agree that I don't want to go for a labor, I want to wait for my natural labor, this patient, and she reaches, what will you tell her? How will you counsel her?
We will counsel the patient and we will increase the monitoring.
What will you counsel the patient? What will you tell her? She says, what is the harm in my babies are moving? What will you counsel?
Ma'am, we will counsel her that to rest. If she wants to go for normal delivery, we should prevent her mobilization to prevent early rupture of membranes. And
No, early rupture of membrane तो खत्म हो गया, preterm ही नहीं है, तब क्या खत्म हो गया? Huh? You want to deliver by 38 weeks. She says, I want to wait till 39 weeks. What will you tell her? What is your risk?
first twin, Ma'am, if first twin is vertex, then ma'am, we can go for normal delivery. But ma'am, if
No, I didn't ask you the mode of delivery. I asked you,
asking-
she doesn't want.
Ma'am is asking
She-
that
Yeah.
this twin of you is 37 weeks. You want to plan for birth and you want to admit her for delivery, but she says, I want to wait till 39 weeks. What is the main risk that that is why the
Yeah.
guideline has said later. What is the main risk that we are concerned about?
ma'am, perinatal.
I don't want my.
Yeah, intrauterine fetal death. There's a
Correct.
higher deaths reported after 38 weeks. So if the patient does not agree to you, you tell her this is the risk, but we will increase monitoring, but we can't give you 100% surety. You understand? That is what.
Birth rate.
So now, shall we finish the mode of delivery? All right. How do you monitor the babies in labor if you're and which one will you decide normal? Which one will you decide cesarean? And if you decide normal, how will you monitor? Then we'll come at the complications.
Ma'am, if the presenting twin is vertex, then we can, and there is no other contraindication for vaginal delivery, then we will decide for normal delivery. And if the presenting, and there is no discordance between the two twins.
And there are no obstetric indication for
Okay.
cesarean.
No risk factor, no contraindication to vaginal delivery, both fetuses not having a significant discordance. First fetus, cephalic, right? And then second is breech. So decided to give her labor. How do you plan labor? You know, what are the prerequisites you look for in this patient? You are giving the vaginal delivery, she's 38 weeks.
Ma'am, 2 trained obstetricians should be present, 2 neonatologists should be present for both attending for one fetus each. There should be 1 anesthetist available on the floor. Ma'am, there should be a portable ultrasound available to rule out the second lie of the second baby. Blood should be arranged, ma'am.
And fetal monitoring, we will do
Continuous
the fetal monitoring with 2 CTG machines.
So how do you monitor these fetuses?
Ma'am, 2 different probes are used, CTG probes are used,
Two
preferably
probes or
by
2
2 different people,
people.
and the difference of heartbeat should be greater than 10 to 20 weeks, but and should be 10 centimeter apart. Both the probes should be 10 centimeter apart.
So suppose you can't locate the second fetal heart. You should also see maternal pulse to avoid a mistake. You understand? You can't see fetal heart with your tocodynamometer, whatever monitor you have. What is
Ma'am,
what will you do? You are monitoring her labor. Second
we
fetus,
have
you can't
ultrasound
hear the
here.
fetal heart.
Ma'am, we
Ab
have
kya karoge?
ultrasound there, so we will.
Yes, you can use ultrasound to localize the fetal heart. Many times tocodynamometer you cannot hear, or otherwise also it is difficult to. So as you said, then ultrasound in the labor room is important for twins, and that is where it comes. You can localize the fetal heart of both the fetuses and then put the probe and monitor. And if there's membranes are ruptured, if you want to do internal fetal monitoring, which we are not using it, that's fine. So now your first baby has come out nicely normally. What is your line of management now?
Ma'am, we will withhold the oxytocin as part of active management of 3rd stage of labor, and then we will determine the lie of the second.
First, you'll determine the lie,
And
then
the
think
lie of
about.
the second twin, whether it is longitudinal or not. If we are not sure,
Yes.
we can use ultrasound also.
Correct,
We will
correct.
wait for the baby to descend into the presenting part to descend into the cervix. We can
Mhm.
Then we can do an ARM and start on oxytocin, and then we see the
Once the presenting part has descended well into the pelvic cavity, then only think of rupture. Normally they deliver within 30 minutes.
Don't be in a hurry.
You should know how to do a breech delivery if that is breech. Let the breech come out like the breeches come out. You don't have to pull a leg or do anything like that, right? If the second fetus goes in a transverse line, now what is your option?
Ma'am, we can do a external cephalic version if it is successful.
Which version?
External
Which version?
She's saying external cephalic.
Yeah, I think if the membranes are intact, that's easier than the internal
podalic version. All of us are not tuned to doing that. They're not happening also. But if you're comfortable, members of you can go ahead and do a internal podalic. What will be a situation you have to do a cesarean for second of twins? As the second twin, something happens and you have.
If there is any accidental change of lie, any sudden bleed, or there is cord prolapse.
Yeah, the accidental hemorrhage, a cord prolapse, a lie you can't manage, or fetal distress. You have
Fetal distress.
these are things when it's not that common, that you think. And what is the recommendation for third stage? Then Dr. Chanchal, you ask her all the unique complications. We left them. What is the third stage?
One question.
Then,
more question.
active management of third stage of labor is done, and the placental examination is done for the membrane.
Yeah.
Cotyledons are intact or not, for the membranes also.
And the membranes.
You were saying something, Dr. Chanchal, we left out something.
I wanted to ask you that suppose the first fetus is out, the first twin is out, and the second one is cephalic. You've confirmed the presentation of the scan. The mother is contracting, but it is still higher up and membranes are intact. The fetal heart rate is reassuring. Is there any particular time limit? What do the guidelines say? Is there a particular time by which the second twin must be born?
30 minutes.
Ma'am, preferably within 30 minutes, but we can give it longer.
So the current guideline says you can wait forever.
Yeah, you
If
can
the-
wait forever. Correct.
fetal
As long as the
condition
fetal heart
is-
remains normal, you can wait.
Yeah.
You have to do a continuous
you-
monitoring for that. Agree with that, absolutely.
Doesn't have to
Majority
deliver
they
within
deliver.
half an hour.
That's it. One odd case will happen that they will not deliver. So now let's ask you the complications of unique complications of twins. Dr. Chanchal, please start.
One trick question I have. These girls have really presented very nicely. So I've gone back to the basics. Can a dichorionic twin be monozygotic? Can a dichorionic twin pregnancy be monozygotic?
Yes.
Yes,
Yes, ma'am.
Yes, ma'am.
Yes. So there's a difference between zygosity and chorionicity.
And chorionicity, correct.
Yes, because a monozygotic can be either monochorionic or dichorionic depending on the time of splitting. However, the complications that we talk about, which Mama has asked me to come to, complications are unique to monochorionicity. They're not related to zygosity. Are we clear with that?
Yes,
All
ma'am.
monochorionics will be monozygotic. However, dichorionics can be either.
Yes,
Right?
true.
This is important. And the complication is decided by the chorionicity and not by the zygosity.
Absolutely.
Okay? So what are the unique complications that can happen to a monochorionic twin pregnancy?
Twin-to-twin transfusion syndrome.
So let's start with the first trimester, as ma'am enumerated that when
There are chances of abortion, spontaneous abortion.
increased risk of miscarriage. Second,
Ma'am, congenital anomalies.
right, and
Vanishing twin or single fetal demise.
two.
Ma'am,
This is where you're, in the
fetal-
first one, yeah.
You did say death of death of one fetus. Did you say that? Yeah.
Yes, ma'am, single fetal
Achha,
demise.
fine. Single fetal demise.
Yeah, before that, I mean, you're doing an anomaly scan, so you said that there is increased risk of
Vanishing twin, ma'am.
vanishing fetus. Okay. Third, acardic twin.
Acardic
आपने पहले
twin.
बोला है, you have said, yes. So acardic twinning, trap sequence, and then you come to the second trimester, wherein now the three complications that we monitor them for.
Fetal, ma'am, a twin-to-twin transfusion, fetal growth restriction,
Right.
discordant growth.
And the fetal
And
growth
the
restriction.
twin anemia,
And
polycythemia
Sequence.
So let's approach each individually. The commonest is the selective fetal growth restriction. Is the diagnosis any different from dichorionic twins? What do you know about selective fetal growth restriction in monochorionics? Hello.
Yes, ma'am.
Ah,
Ma'am,
so,
in monochorionic twins, the effective in selective fetal growth restriction, the effective fetal weight is less than third centile. The basic difference is, ma'am, that we take the abdominal circumference also in
Also.
monochorionic.
so in
In less
what
than
is
10 centile, AC less than 10 centile.
so in monochorionic twins, again, discordant growth, the definition is same, that
Yes, ma'am.
discordance is more than
25%.
Yeah. Yes, more than 20% should be flat. There are various guidelines.
That is, yes, ma'am. More than 20
Yes.
is flat, more than 25 is discordant.
Right. And in this particular twin, you are looking at Dopplers right from 16 weeks onward. So
Yes,
the
16
selective
weeks,
fetal growth
by
is
week, twice, two weekly. 16 after 16 weeks, 2 weekly. For twin to twin.
you're doing Dopplers also. Yeah.
Ma'am.
So what I'm saying is you're seeing a twin pregnancy at 19 weeks. It's a monochorionic diamniotic pregnancy.
Yes,
Once
ma'am.
fetus is smaller and the discordance is more than 25%, how would you manage a monochorionic pregnancy with this kind of a growth restriction at 19 weeks? What additional information do you need to classify this selective fetal growth restriction? So I hope I'm asking MCDA with selective fetal growth restriction. How do you manage?
Ma'am, we will go for Dopplers.
What is establishing the diagnosis? Selective fetal growth restriction is classified into 3 types in monochorionics, which is different from the chorionics. How do you do that?
Ma'am, we take estimated fetal weight less than 10 centile. Then we say umbilical artery PI greater than 90th centile and abdominal circumference less than 10 centile.
बेटा नहीं इसमें selective FGR के 3 they are labeled differently, है ना? Depending on the umbilical artery blood flow.
Umbilical artery Doppler, ma'am. We will see in the smaller twin. Umbilical artery Doppler, whether it is whether there is absence or reversal of end diastolic flow in the smaller twin.
Yes.
Or there
Yes.
is any
So-
abnormality in the ductus venosus of the smaller twin.
No, so
No,
I think
I think type 1, 2, 3, I think you
First, ma'am,
explained
before
and
we
I got
take the
confused
umbilical
again.
artery Doppler only, it will start from changes in umbilical artery Doppler, then it will go further, like the deterioration will go further.
No, I don't think you're understanding her question. She's just
I will-
type 1, 2, 3. That's it. Chantal, please explain them, I think they don't know that.
So in monochorionic twins, once you have selective fetal growth restriction, which we have established that one fetus is less than 10 centile and discordance is more than 25%, I will classify this SFGR into type 1, 2, and 3, depending on the umbilical artery blood flow. If the end diastolic flow is present, it is type 1. If it is continuously absent, it is type 2. There is a typical pattern which is intermittent. It goes from present to absent to reverse and comes back to normal. That is type 3. Okay, so there are 3 types of selective fetal growth restriction in monochorionic pregnancy. This classification is given by Gratakos. That paper from White Journal is available freely on the net.
I don't think it's given in their textbook. I think we read it, saw guidelines. So I think it's good to teach you this if you don't remember that.
And it is important to do this classification because it tells you about prognostication, what to expect.
Yeah.
The connotation when you see a reversed or absent end diastolic flow at 19 weeks in a monochorionic is very different from what you would see in a dichorionic pregnancy. Because in monochorionic twins, these Dopplers take way longer to deteriorate. They may take up to 6 to 8 weeks to deteriorate before delivery is necessary. That is why this classification is very important.
Yes, ma'am.
Right?
Right.
Yeah.
So now they've said, TTS, they've said, death of one twin, what will you do?
Yeah.
What is the risk in a dichorionic? What's the risk in a monochorionic? One twin dies at 32 weeks.
Ma'am, in 25%. In dichorionic, the risk is
Dichorionic, there's a risk of
in
other
monochorionic,
fetal death. Not one
certain-
dies. So what is the risk to the other fetus in a di and in a mono?
I mean,
So you were
monoclonic
13
it is
meters,
25%.
yeah. Would you deliver it immediately? You have 31 weeker MCDA twin who comes to you with decreased fetal moment. She was following up regularly, and then you find that one heartbeat is not there. Would you deliver her?
No, ma'am, based on chorionicity, it's dichorionic expectant management is
I'm talking about monoclonic. So let's take both scenarios. As ma'am, actually, ma'am wanted to ask
and
this.
management in monochorionic depends on the time since fetal death, ma'am. If the fetal death has occurred within 24 to 36 hours, ma'am,
Ma'am, at 31 weeks, we will decide to deliver.
So no, the answer is no, because when, see, in monochorionic, what ma'am was asking was that if there is a single demise in a dichorionic twin, because there are no interconnected blood flow, the chances is minimal. Though literature says that MRI findings abnormalities were slightly higher in the surviving co-twin, even in dichorionics, we can more or less reassure them that the risk to the co-twin is extremely low. Now, in monochorionics, as you rightly said, that there is a 20 to 25% risk of either co-twin demise or, more importantly, the neurological damage. However, whatever injury has to happen. It happens at the time when the heartbeat stops. So expecting the delivery will not be very helpful at this 31 weeks.
Sure.
So you will.
That's what else they've left now. All right, if one fetus is anomalous and the other is normal dichorionic, what will you do? And monochorionic, what will you do? Let's say it's a lethal anomaly in one fetus. Mid-trimester scan.
Ma'am, we can go for fetal reduction.
20 weeker scan, one fetus is a lethal anomaly, one is normal. What will you do? We've said death of single twin, we sorted. Now anomaly in one twin, what will you do?
Ma'am, we can go for selective.
Quick, because time is little.
selective fetal laser coil.
क्या बोल रहे हैं?
In case of dichorionic, ma'am,
Dichorionic, one twin, that lethal anomaly, one is absolutely normal. Dichorionic, what will you do?
reduction, ma'am.
So if it is a lethal anomaly,
Yeah.
anyways, I mean, what are the risks and pros and cons that you will weigh?
Ma'am, dichorionic as single fetal demise, we can go for
Demise नहीं है, anomaly है. Demise तो हो गया. This is anomaly, lethal anomaly in one twin. What will you do? What will be your counseling to the patient? What are the options you have to manage this pregnancy?
Ma'am, we can counsel the patients that about the that one fetus has lethal anomaly, but the other is normal. And in dichorionic, even if we will explain them, there is risk of intrauterine death, so we can counsel them that we can continue the pregnancy and wait for normal twin to deliver.
What management options do you have, and what are the advantages and disadvantages of both?
Yeah.
DCDA twins, in one fetus, what options do you have? Risks versus benefits.
It depends on the anomaly.
See, in NM, you want me to answer this, ma'am, quickly? 3 minutes
ma'am.
left.
I think time is running, so I don't think they can answer that.
Whenever we talk about selective reduction, there is an inherent procedure-related risk of miscarriage because of the procedure itself, because you are leaving a dead tissue behind. In the first trimester, that risk is about 3 to 5%. However, at 20 weeks, that risk is almost 16 to 18%. In lethal anomalies, they do not want to take that risk and may want to continue the pregnancy.
Continue.
However, in anencephaly, because there is a risk of polyhydramnios in the co-twin, there you have to discuss it with the couple that because of the increasing polyhydramnios, I will have an increased risk of premature delivery. So all lethal anomalies may not be. If it is a hypotensive left heart. The fetus will not may not survive after birth. So these are always very challenging situations. Weighing the risks of procedure-related complication vis-a-vis expectant management and losing the baby in and after delivery. So,
Right. Did you get that?
Yes, ma'am.
Constant whether she can continue pregnancy, as she said, and normally having polyamorous, you got to do something, a complex heart or any of the abnormality which is which is incompatible with life, all right. It doesn't cause like a problem. So then you can even tell her to continue pregnancy. I mean, option is hers.
offer palliative care postnatal.
Yeah.
Yeah. Right. I think we've covered almost.
Death. Yeah, almost all death. All right. When do you start brain aging after death of one twin? We didn't see the time. Death of one twin, you want to, can't do anything now, whether it's mono or die. The chances of neuro handicap is more in mono than in die. When do you start imaging? Immediately after?
No, ma'am.
What's the time interval between death of the fetus and the time of imaging?
For 6 to 8 weeks, ma'am.
Sorry?
6 to 8 days.
I didn't hear her. What did you say?
You're right. And
4
6
to
to
6.
8 days.
yes, it's minimum 6 weeks.
Minimum 6 weeks.
Yeah.
MRI can be done. Neurosonographers can even point it out as a neurosonography. That's part with them. You have any queries? The audience has any question? We have a minute or only 30 seconds left.
I have one question. One
I
question.
didn't see anything in the chat box. I didn't
I've
see.
answered one. For our students, a DCDA twin comes to you at 12 weeks, and you find that one fetus is growing appropriately and the other stopped growing at 9 weeks. Would you do a dual marker for this girl?
There is one.
Yeah.
Part is
No.
if
If you have a visible fetal pole at 12 weeks, you will not do it.
Yeah.
Visible pole is there, we will consider the anti and the maternal age.
Maternal age and anti. Correct.
Absolutely. Yeah. I think we've covered everything now.
They've answered about 70% easily.
They've answered very well.
Nice to have your inputs. You want to ask us anything, the presenters? You have any queries?
Yes, ma'am. We were not able to understand, ma'am, that part when ma'am was explaining about the counseling we will give to the patient when there is a lethal anomaly.
So in a dichorionic diamniotic twin pregnancy, I have a fetus who has an anomaly, and there is a lethal anomaly. For example, there is a complex cardiac defect. So the one option is that I do a selective reduction at 20 weeks, wherein I will explain that because of my procedure, there is a 16% risk that you may lose the entire pregnancy, that you lose the healthy co-twin. Or you don't take that risk, you continue with 4-weekly monitoring as per a twin pregnancy. Come to the co-twin and you deliver as and when required, and offer only palliative care to the anomalous fetus with newborn who will eventually go. Yeah. The situation is slightly different in anencephaly because it itself is associated with polyhydramnios. So individualization is very important in medicine, in obstetrics. If there is exomphalos in the co-twin, that fetus is not going to die. It's a correctable anomaly. But the baby will require postnatal pediatric surgery. So some parents may feel that is too much for them and they would still request for a reduction. So what we were trying to say is that when there is a discordant anomaly, one is normal, the other is anomalous, offer invasive testing for both to ensure that there is no chromosomal abnormality. Management options include expectant management and postnatal treatment or evaluation of the anomalous fetus, or a selective reduction at that point in time, which will be associated with the risk of miscarriage. That would be
Thank you, ma'am.
Okay.
Fine, then we close.
Thank you so much.
Exceeded our time. Thank you, Chanchal. Good to have you. Good to have your inputs. Always nice to see you.
Yes.
Chalo.
All the
Thank
best.
you. Thank you.
Thank you, ma'am. Thank you, ma'am, for well outlined discussion on multiple fetal gestations, ma'am. We move further now. now we are going to discuss about uterovaginal prolapse. And the moderator for this session are Professor Dr. Achla Batra ma'am. She's a consultant in Mata Gujari Hospital and National President of Narchi. We have next Dr. Geeta Mendirata ma'am. She's Vice Chairperson and Consultant, Department of Obstetrics and Gynaecology in Sir Gangaram Hospital. And we have Dr. Anupama Bahadur, Professor and Unit Head in Department of Obstetrics and Gynaecology in AIIMS Rishikesh. Today, the presenter is Dr. Vasundhara, PNB resident. And over to Dr. Vasundhara for the presentation, please.
Ma'am, good morning.
Good morning, Anu. How are you?
I'm good, ma'am. How are you? Absolutely delighted to see you.
Same, likewise.
इतने साल हो गए।
हाँ जी।
एक दिन मैं आपकी स्टूडेंट थी और आप मेरी टीचर थे। अभी भी हो मैम? नहीं, still are.
It's always a pleasure, Anu, to have such brilliant students like you. We learn a lot from students like you. You are the teacher finally. Dr. Achla आ गई है? Vibhushan, can you call Dr. Achla? Anyway, I think we will start. Dr. Vibhushan, shall we start?
Yeah, ma'am, we can start now. Vasundhara is ready for that.
Okay, Vasundhara, please start. Anu, Vasundhara and you and me will start. Dr. Achla hopefully is phone.
A very good afternoon, both of you, ma'am. I will be presenting my case.
Vasundhara, thoda loudly bolo, beta, आवाज नहीं आ रही है.
A very good afternoon, ma'am. I will be presenting my case on pelvic organ prolapse.
Okay, please start.
Ma'am, sorry for the delay. My screen is not changing.
I think you log in again. You stop sharing and then share again. सब चल जाएगा.
Dr. Anupma?
Yes, ma'am.
मैं सोच रही थी let Vasundhara present the history, then we will interject, and then let her present the examination, then interject. Let her speak continuously for the history and the lab बनी रहेगी, है ना?
ठीक है
Ma'am, my patient is 57-year Mrs. X, resident of Nagloi, Delhi, farmer by occupation, belonging to lower socioeconomic class by modified Kuppuswamy scale, is a para 4 living 4 with history of previous 4 normal delivery, last childbirth at 32 years back, postmenopausal since 8 years. She presented to us with a chief complaint of something coming out per vaginum since 3 years, complaint of back pain on and off since 3 years, and complaint of urinary problems and symptoms since 6 months. History of present is the patient was apparently asymptomatic 3 years back when she started noticing something coming out her vagina. It was gradually in onset, progressive in nature. The mass increases on coughing and straining, and it decreases on lying down. The mass was reducible initially on its own. There is history of inconvenience, mechanical irritation, that is inconvenience during walking. There is history of low backache on and off, which is increased on doing household work, worsens as the day progresses, and improves on rest. There is history of incomplete sensation of voiding of urine and poor or weak stream of urine. I asked the patient about whether in her own language that जो धार है आपकी यूरिन की वो कैसी आती है, तो she told कि बहुत पतली है. That's why I came to the conclusion that it's a poor and weak stream of urine. There is history of increased frequency of micturition with 9 to 10 daytime episodes and 3 to 4 nocturnal episodes. Ma'am, the patient has to wake up in the night for micturition. There is no history of any burning micturition, any urgency, prolonged voiding, stress urinary incontinence, any hesitancy, intermittency, or difficulty to initiate the micturition. There is no history of need to manually reduce the mass to urinate or defecate, that is splinting. There is no history of any altered bowel habits, that is constipation or diarrhea. There is no history of abnormal discharge per vaginum, no history of loss of weight or appetite, no history of chronic cough. Ma'am, my patient, she attained her menarche at 13 years of age. She attained her menopause at 49 years of age. Her past menstrual cycle were for 3 to 4 days, for 30 day cycles regular with average flow. There is no history of any postcoital, intermenstrual, or postmenopausal bleeding. Marital history, she is married from 40 years. The age at marriage was 17 years and age at first childbirth was 20 years. Obstetric history, she had her first child at the age of 20 years in 1986. It was a full-term normal vaginal delivery. Approximate weight was around 2.9 to 3 kg as per the patient. It was a girl child. As per the patient was in labor for 2 days. There were no history of any instrumental delivery. The delivery was done at a local government hospital. Her second delivery was a FTNVD girl. Weight was, she was not sure of the weight. It was a home delivery conducted by a dye, and the baby is alive and healthy. The third delivery was in 1989. It was a boy. Weight was not. She was not sure of the weight. It was a home delivery conducted by dye, alive and healthy. The fourth and last delivery was in 1991. It was a full-term normal vaginal delivery boy, 3.7 kg as per the patient. It was delivered at a local government hospital. There was no history of any instrumental delivery. But she gave me the history that there was history of blood transfusion for anemia during the pregnancy. There is no history of any instrumental delivery as per the patient. There is no history of any episiotomy or perineal tear, or there is no history of any complications in puerperium. She resumed to farming work 2 months after delivery. So there is history of inadequate puerperal rehabilitation. The interpregnancy interval was 1 to 2 years. Past medical history, she is a known hypertensive on antihypertensives. There is no history suggestive of diabetes mellitus, bronchial asthma, tuberculosis, any chronic cough, or any connective tissue disorder. Surgical history, no significant history was present. Family history, no significant history was present. Personal history, she has a normal sleep and appetite. There is complaint of altered bladder habits, which I already enumerated in the chief complaints and history of present illness. The bowel habits are normal. Summary, my patient, she is 57-year para 4 living for previous normal vaginal deliveries with 2 home deliveries conducted by a dye with interpregnancy interval of less than 2 years, postmenopausal since 8 years, known hypertensive on treatment with complaint of mass descending per vaginum with increased frequency, poor stream and incomplete sensation of voiding, is probably a case of pelvic organ prolapse.
Okay, we'll stop here. Vasu, we will stop here. Okay? Yeah.
Yes, ma'am.
Anupma, Dr. Anupma.
Okay. So you presented very well. I think you've covered all the points. If you come to your first slide, did you ask about how did you your first slide? This is okay. So did you ask about SUI?
Yes, ma'am. I asked about SUI. I asked her whether whenever she is climbing the stairs or coughing or laughing or there is leakage. Basically, मतलब उनका जो सलवार है वो गीला हो जाता है. In her language, I asked that, ma'am.
Okay, very good. So there is no discharge, no loss of appetite, no cough. Very good. Can you tell me what?
I didn't mention here, but I also asked her about the water intake because there was increased frequency of menstruation. So I also wanted to rule out whether she has any polydipsia or plus diabetes. I took that in medical history also, but I was not knowing where to mention, so I didn't mention it.
Okay.
I mean, because she's a hypertensive, na? So did you ask what medicine she's taking for blood pressure?
Yes,
Because
ma'am.
many of them.
I asked, ma'am. I didn't mention it here, but she was taking Telma, Telmisartan, 40 milligrams once daily.
Okay.
Yeah. So you
And
ask in these
yes, ma'am.
patients.
So your differential diagnosis, according to, you diagnosed her as a case of pelvic organ prolapse, right?
Yes, ma'am.
What is your differential diagnosis and what are your points in favor of pelvic organ prolapse?
Ma'am, firstly, there is history of something coming out from the vagina, which is not reducible, plus causing her mechanical irritation. That means I haven't examined the patient, but based on the history, that is like her history is reliable. It means there is something coming out of the vagina. Now she is also having some urinary complaints plus backache also. These all are the points which favors towards pelvic organ prolapse.
Okay.
And also the frequent childbirths,
Yes,
inadequate
ma'am, that also, ma'am,
rehabilitation. So you should say that, madam,
inadequate
because of
puerperal
these pre-existing factors.
Yes, ma'am. Inadequate puerperal rehabilitation, plus there is a history of 2 normal deliveries at home. The interpregnancy interval is also short, like less than 1 to 2
year.
2 years.
And you mentioned history of anemia and receiving blood transfusion.
Yes, ma'am.
So now just going on to a bit of pathophysiology, you mentioned about patient is having incomplete emptying of urine and nocturia and the splinting. What is the mechanism of these urinary issues in a patient with pelvic organ prolapse? Why do people have this?
Ma'am, firstly, I will start with urinary complications. Like urinary complication can be in form of where she can have either SUI or she can have either urgency. The stress urinary continence, as my patient is 57 years, she is postmenopausal. Hypoestrogenemia can be there. Plus, she has a history of anemia also. So anemia, malnutrition, hypoestrogenic condition, these all leads to the collagen and connective mucosal coaptations of the bladder are disturbed, and there is, ma'am, basically there is like
they will have SUI. What you are telling me is the pathophysiology for SUI.
Yes, ma'am.
Asking when there is a prolapse, a pelvic organ prolapse, why does such a woman have
because the urethra
emptying of urine?
From the intra-abdominal organ, it becomes the pelvic organ, plus there is hypermobility also. Plus, ma'am, because due to the normal deliveries, there is dragging of the all the ligaments, the pelvic fascias, which is attached to the arcus tendineus fascia pelvis. There is damage of the loss of the anatomic hammock that is supporting the
Vasu, listen to the question. I am not asking you why the prolapse has occurred. We know the Delancey levels of support, they have been disturbed. So if it is level 1, some structure will come down, level 2 will lead to some other structure coming down. My is a very simple question that when a patient with a prolapse, Dr. Anu, why I'm asking, because Anu asked you, what is the differential diagnosis? If it's a urethral diverticulum, she wants to know, na? Can it be a diverticulum, be a cystocele, can it be an anterior vaginal wall cyst, Gardner cyst, Bartholin cyst? So that is what I'm trying to make you say the answer to Dr. Anupma's question when she asked what are the, you said it is a prolapse. So prolapse की औरत को ये problems होती है ना. अब मेरा सवाल है prolapse की औरत को ये क्यों problems होती है ये बताइए. Why she will have an incomplete emptying of urine? Why she will have to do splinting?
Ma'am, because the mechanism of continence is disturbed. Plus, the mass is there is
So
obstructing.
it's basically the bladder is descending out of the abdominal organ and from an intra-abdominal organ, the uretrovesical angle split. It slips. So that is why they have to do splinting. They have to reduce the prolapse to
the prolapse.
the correction of the uretrovesical angle. Yes.
Yes.
So
Yes,
you
ma'am.
tell Dr. Nukma that because she is doing splinting, that means she's trying to correct the uretrovesical angle. In diverticulum, there is no splinting. Gardner's cyst, there is no splinting. Then your patient also has a nocturia.
But ma'am, in my patient, there was also no history of splinting.
But in a prolapse patient, sometimes they give history of
splinting history. Yes, ma'am.
Yeah. We are asking the effects of prolapse. We are not asking you the causes of prolapse.
Yes, ma'am.
Now you tell us the causes of prolapse. Now you tell us in brief, what are the causes of prolapse?
Ma'am, can I just add her?
Yes, yes, Anu.
So the other differential can even be your fibroid polyp and a chronic inversion of the
Ma'am, it can be a large fibroid polyp. It can be a Gardner's cyst.
Yeah,
it
Gardner's
can be
cyst.
chronic inversion case also, ma'am.
Yeah, okay.
Ma'am, I will be answering. There can be predisposing factors. There can be in predisposing factors, genetic factors can be there, racial features can be there, family history sometimes it is given in literature can be there. In genetic factors, there can be congenital weakness of the tissues which is formed in connective tissue disorder, congenital collagen tissue disorders such as Marfan or Ehlers-Danlos, in which there is hyper mobile joints and inherited weakness of the collagens. Ma'am, then inciting factors, pregnancy is the most important. If there is weakness of the fascia and the ligaments due to hormonal changes of the pregnancy, as well during delivery, when the vaginal delivery is the most important and established risk factor. In case of difficult or prolonged labor, there is damage to the perineal floor innervation, and the ligaments and the fascias all are damaged. Plus, ma'am, there can be any during.
Can you be a little more specific, Vasu? Answer specific.
There
is incurred during childbirth.
Over distension of the uterus, there is dragging or of the uterosacral ligaments, plus the pelvic, the lateral pelvic fascias which are connected to the arcus tendineus fascia pelvis. These all are because of the over distension of the uterus. They all, ma'am, they are stretching, and there is tearing and breakage of the tearing and break of the fascias, ma'am.
So vesicovaginal fascia and rectovaginal can be torn, or the attachment at the lateral pelvic wall, attachment occurs. So there is a dissensus. Yes. Okay. Let's start with the examination now.
Yes, ma'am.
Can you examine your patient and tell us?
Yes, ma'am. On general examination, my patient is conscious, oriented, moderately built and nourished. Moderately built and nourished. Her height is 158 centimeter, weight 53 kg, BMI 21.2. Mild pallor was present. There is no icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. Her pulse rate was 86 per minute, regular in rate, rhythm, and volume. Her blood pressure was 130 by 70 millimeters of mercury, measured in right upper arm in sitting position. Her respiratory rate was 18 per minute. Thyroid, breast, and spine and gait examination was normal. On systemic examination, S1 and S2 heard. There was no murmur. Respiratory system, normal vesicular breath sounds were heard. There is no added sound. On CNS examination, there was no focal neurological deficit. On per abdomen examination, on inspection, the abdomen was scaphoid. Umbilicus was in midline inverted. All quadrants moved equally with respiration. There was no sinuses or dilated veins. Hernial sites were intact. On palpation, abdomen was soft, not tense, non-tender, no organomegaly, no ascites. On auscultation, normal bowel sounds were heard. On local examination, on inspection, the external genitalia appeared normal. Sparse atrophic hair seen over the genitalia, decreased labial pad of fat. There was gaping of the introitus. An oval pinkish bulge of 3 by 4 centimeter was seen protruding through the introitus, with cervix as the leading point. Dry vagina, the rugies were absent. No decubitus ulcer or keratinization was seen. The stress urinary incontinence was not demonstrated. I asked the patient to cough, and there was no spurting out or leakage of urine from the urethra. On palpation, the inspectory findings are confirmed. Cervix is the leading point. The mass is reducible. I was not able to get over the swelling. Mass descends further on cuffing and straining. Occult incontinence was not demonstrated. On per speculum examination, anterior compartment, a bulge was noted in upper 2/3 of the anterior vaginal wall, probably cystocele. In middle compartment, I could see the cervical descent based on the position of the external os. In the cervix was normal looking. There was no keratinization or ulceration. In the posterior compartment, there was a bulge in the upper 1/3 of the posterior vaginal wall, probably an enterocele. On bimanual examination, the uterus was retroverted, normal size, mobile, bilateral fornices were free. On per rectal examination, it was normal. The rectal mucosa was free. External anal sphincter and tone was normal. External anal sphincter tone was normal. The reflexes, sacral reflexes, bulbocavernous and anal wing reflex were elicited and are normally elicited. On the inspection of the perineum, deficient perineum was noted. I went for the levator and eye muscle bulk and the tone, and based on the modified Oxford muscle power grading, it was 2 by 5. Then I did the POPQ staging of the pelvic, the vaginal bulge. The AA anterior point was at +3. The BA point was at +5. The C was at C, that is the cervix was +6. Genital hiatus was 6 centimeter. Perineal body was 2 centimeter. Total vaginal length was 8 centimeter. The points in the posterior, that is AP, was -2. BP and the D was -10. In total summary, my patient is a 57-year-old para 4 living for postmenopausal. Year para 4 living for previous normal delivery with 2 home deliveries conducted by DI with a short interpregnancy interval. Postmenopausal since 8 years, known hypertensive on treatment with mass descending per vaginum with increased frequency of micturition and incomplete voiding with vaginal prolapse, cystocele and enterocele.
So what's your diagnosis?
Ma'am, my patient is a para 4 living for postmenopausal female with a stage 3 pelvic organ prolapse with cystocele, with enterocele, with known case of hypertension on medication.
We don't use these words cystocele and enterocele. What are the words we use now? Stage 3 pelvic organ prolapse with leading point.
C. Ma'am, it is a stage 3 pelvic organ prolapse with the leading point as C. That is +6 with.
How do you determine what is the leading point? How do you determine the leading point?
Yes, ma'am. Ma'am, I did the POPQ.
So what is the leading point? How do you determine whether it is AA or BA or C? How do you determine that?
Ma'am, we will do the pelvic organ prolapse quantification staging. Firstly, we will examine the patient as per the pelvic organ quantification. Ma'am, the most
is which point? The point which has got the highest marks is the leading point.
Leading edge, yes, ma'am.
Okay, now go back to the examination. One by one we will discuss. Go back to the examination. Okay, so this is all right, the atrophic vulva vagina. Next, how did you demonstrate SUI? What did you ask?
Firstly, I examined the. Firstly, I told the patient, she should not evacuate the bladder. The bladder should be
Exactly. So prolapse patient should always be examined with a semi-full bladder. Don't ask the patient, like usually in a gynae OPD, we say, please pass. But in a prolapse case or a patient who's complaining of urinary problems, always examine them in a full or a semi-full and then, okay, next.
Then, ma'am, I explained the patient and tell her to be in the dorsal lithotomy position. Then, with the thighs and the legs flexed and abducted, then I asked the patient to cuff or to strain or do Valsalva. And but then I inspected for any leakage or spurting from the urethra of urine.
So when you say SUI not demonstrated, you should also say whether there was any hypermobility of the urethra, because some uretrovesical angle moves down, you know, it rotates or on its axis and comes down. So you should have mentioned that. Next.
Yes.
So you, ma'am, can I just ask one question?
Yes,
here?
yes, please go ahead, Anu.
So you've mentioned gaping of the introitus. How did you measure the perineal body, and how many muscles are there? There are 9 muscles. Can you name them?
Ma'am, in inspection, actually, I just I went for the inspection, like what I was seeing. According to my visual only, I wrote that the gaping of muscle was, gaping of introitus was there. Beside that, ma'am, the muscles of the perineum are the levator ani muscle, which consists of the iliococcygeus, pubococcygeus, and ischio-coccygeus. Ma'am, they are both sides. They are both. They are like 2 in number, ma'am. Istio, ilio, istio, and pubis. Then there is transverse perineal.
Name the muscles.
Ma'am, iliococcygeus, ischio-coccygeus, pubococcygeus. Then there is transverse perineal muscle, deep and superficial. There is bulbospongiosus, and then istiocavernosus, and then, ma'am, the external sphincter muscles, ma'am.
Okay, so total 9. And the perineal body you measure from the fourchette till the mid-anal opening. Okay.
Ma'am, I am not able to hear you.
Okay. You are not able to hear me.
Now I can hear you, ma'am.
Okay.
Anu, you speak in the mic a little closer.
Okay. I just said that you measure the perineal body from the fourchette to the mid-anal opening. That is what I told her.
Ma'am, that I did
that you did in your POPQ. Okay, fine.
Ma'am,
Hi,
that I did POPQ, ma'am. In inspection, I just wrote on the inspection, inspectory findings.
Okay, next slide.
Can I just make a point here?
We welcome Dr. Karishma.
I'm sorry, I am replacing Dr. Achla. Dr. Achla was supposed to be here, and ma'am.
I was wondering how come Dr. Achla has changed.
Anyway, Karishma, we are doing the examination of a prolapse, and one by one we are.
Ma'am. I have heard the examination. There's just one little point that I want to make here. Can you just go back to the last slide, please, Dr. Vasant?
Yes, ma'am.
नहीं, इससे पहले वाला slide जो Dr. Anupama जिसमें पूछ रहे थे आपसे. So when you write an oval pinkish bulge of 3 × 4 centimeters seen protruding through the introitus with cervix as the leading point, while we're examining, we usually can make out if it's a cyst or not.
Yes,
you can very well see right here that an oval pinkish bulge of the vagina seen protruding out. Because when you're getting your examination findings, they मतलब उससे समझ एक visual impression मिलना चाहिए examiner को कि आप क्या बता रहे हो.
Yes, ma'am.
And then Dr. Anupama asked you to name the muscles. You said iliococcygeus, pubococcygeus. These are parts of which muscle?
Levator ani, ma'am.
Yeah, so you can say levator ani as a whole. And we don't now we just classify it as pubovisceralis and ischio-coccygeus.
Yes, ma'am.
Pubovisceralis has its different parts. Ma'am was asking you the components of the perineal body.
Yes, ma'am.
तो perineal body में आप ये 3 muscles अलग से count नहीं करते, आप levator ani को as a single muscle count करते हो.
Yes, ma'am.
And she asked you, why did you say that the introitus was gaped? Or how could you say that the introitus was gaped?
Yes,
So you
ma'am.
will say that normally how big is the introitus normally? नॉर्मल कितना होता है, तभी तो हम बता सकते हैं ना कि गेप्ड है, छोटा है.
4 centimeters, ma'am.
Yes, and normal dimension of perineal body is?
A perineal body is, ma'am, 2 centimeters, 4 centimeters.
Normal
2 is in normal. 4 centimeters.
Normal perineal body. And similarly, genital height is also normally is 4 centimeters.
4
so
centimeters.
visually appearing to be bigger than that, you will say that it's bigger, or it's gaped, or it's open.
Yes, ma'am.
Okay, we can now move to the next slide.
Next slide, Anup, Basur, next slide.
Yes, ma'am.
So now, next slide.
Ma'am, I have
Now you have said that you have confirmed the inspectory findings. Cervix is the leading point. Mass is reducible. Now on palpation, how did you say mass is reducible? Did you put, or did you ask the patient to put it back?
No, ma'am, I put it back.
Okay. So you have said mass is reducible, but in your history you said mass used to reduce on its own, and now it is not. So you have to clarify in the history that previously that was reducible on lying down, but now patient says even on lying down it doesn't reduce.
Yes, ma'am.
Right. So what all positions do you examine a patient of prolapse?
Ma'am, what?
What are all the positions in which you will examine a case of prolapse?
Firstly, ma'am, we can examine the
This is in the dorsal lithotomy, I assume.
Yes, ma'am. Firstly, we can examine the patient in standing position with a stool, with one leg on the stool and other leg on the foot on stool and other on the ground. Then we can examine her in a Sims position. Then we can examine her in a squatting position, because sometimes patient come to us with a complaint of sensation or feeling of something coming, but we can't see it, we can't find it on examination.
Right. So in the patients in which you cannot discern, then you can ask them to do this, but any prolapse patient you should examine in all these three positions: dorsal lithotomy, squatting position and standing position, so that you can determine and do the POPQ in the most protuberant state of affairs, right? How do you demonstrate occult incontinence? You have written it is in this patient. Tell us the procedure for the occult incontinence demo.
Firstly, the same as a SUI, the bladder should be semi-full. Then we will, in the dorsal lithotomy position, we will ask the patient to do Valsalva, and with our 2 fingers, that is index finger and middle finger.
So first you will do Valsalva, or first you will?
First, we will insert the finger, ma'am. First, we will insert the finger, and then
you insert fingers or?
Yes, ma'am.
You don't insert fingers. You either take a sponge forceps.
Yes, ma'am. Either I was going to tell both the things, ma'am. Either we can use 2 fingers, or we can use a sponge forceps also. Then we will lift up the lateral angles, and we will ask her to cough. If there is no leakage of urine or spurting, then occult incontinence is not demonstrated now.
And if it is demonstrated, what does it mean?
Ma'am, then that patient, it is more of like, ma'am, basically when we do Boney's test or that.
So if a patient has an occult incontinence, it means that she will need to be, at the time of prolapse repair, she will need an anti-incontinence.
Yes, ma'am, anti-incontinence.
Yes, repair also.
Okay.
Yes.
I would like to make here is, whenever you examine whether the prolapse is reposible or not, or whenever you're doing the palpation, ideally the bladder should be empty, because the staging of the prolapse changes with full bladder.
Yes, ma'am. Yes, ma'am.
So, जब आप अपने examination findings में, you will put occult incontinence first, and then you will say that after this I asked the patient to empty her bladder, and then I re-examined the patient, and then you carry on with your further findings.
Yes, ma'am.
Because in full bladder, the staging of prolapse will change.
Yes, ma'am.
You know? You have nowhere mentioned.
That's what we discussed, Karishma. In the beginning, we discussed that patient should enter your clinic with a semi-full bladder and then also examine with the bladder empty later on. But this is one patient where don't say pass the urine and lie down. You should always get them with the bladder because easier to empty and examine, right?
After occult SUI, ma'am, we will ask her to empty because then the staging with the full bladder, it will with the cystocele will appear bigger in size and higher. There's a stage, मतलब up till one stage का difference हो जाता है. So she has nowhere mentioned कि bladder empty किस point पे कराया या नहीं कराया. So that is
Right. So now you have no keratinization or ulceration. Now, what are the causes of keratinization or decubitus ulcer? Why are they caused?
Ma'am, because of gravity or mechanical, mainly because of gravity or mechanical irritation, ma'am, there can be ulceration or keratinization of the most distal or most dependent part of the prolapse, ma'am, because of which there can be discharge in the patient.
And also venous congestion.
Yes, ma'am.
So how would you describe the decubitus ulcer if there was any in this patient? Suppose she had a decubitus ulcer, how would you describe it?
Ma'am, we will describe first starting from we can see any discharge, then about the ulcer, where it is present at which o'clock position as per the anterior or posterior lip of the cervix, then the margins of the ulcer, then the base of the ulcer, and ma'am, yes ma'am, any discharge.
And the size of the ulcer?
And size of the ulcer, yes ma'am.
Okay.
How do you examine
And
the posterior wall?
Bleeding.
You differentiate erecto-entero?
Ma'am, basically, when we are doing the perispeculum examination, the Cuscos, there are two, the Cuscos and the Sims. The Cuscos can give us a picture of about the cervical descent and the cervix. The Sims speculum is used to examine for any anterior compartment or the posterior compartment defect. So what we do, we tell the patient to be in the Sims position with one leg extended and the other leg flexed, and then we insert the Sims speculum and we retract the anterior vaginal wall with a anterior vaginal wall retractor along with the uterus, and then we start taking the Sims speculum. We start gradually taking it out, and we see for any bulge in the posterior compartment. Ma'am, there can be bulge in the middle upper 1/3 and the middle 1/3. In the upper 1/3 it is enterocele, in the middle 1/3 it is rectocele, plus there will be a sulcus between there will be a transverse sulcus between the enterocele and the rectocele, plus when we will do the per rectal with the bulge, there will be gurgling sound in the enterocele. It will be not present in rectocele, plus the fingers will be proximated in the rectocele, but we will be not able to proximate the finger. Like both the fingers, ma'am, the one in the vagina and the one in the rectum, they will be proximated in the, we can feel the fingers, each other. Plus, ma'am, then we can go for imaging study.
Imaging you do. Okay, now anterior vaginal wall bulge. Dr. Anup has already to the DDs. Can you tell me how you will differentiate whether it's a diverticulum, whether it is a Gartner's
diverticulum or Gartner? Ma'am, in Gartner's cyst, when we do the Foley's catheterization, we will be not able to feel the Foley's bulge in the Gartner's cyst. Ma'am, second, when we introduce a bladder sound, we can feel the bladder sound in the the edge of the bladder sound in the urethral diverticulum. Plus, the Gartner's cyst is the remnant which is present in the anterolateral part of the part of the vaginal introitus, but upper anterolateral. But
that's a very important differential point, because cystoceles are present in a different location. Gartners are usually anterolateral.
Yes.
Urethral diverticulum.
Urethral diverticulum, ma'am, firstly, we will able to palpate the Foley's bulb if we are catheterizing it, or the bladder sound. The distal end will be palpable. Second, when we will diverticulum, when we will press the urethra below the urethra, there will be ma'am first drain from the urethra.
So any thick discharge can come up.
Yes.
And polyp or a chronic inversion of uterus, how will you
And for a fibroid
differentiate?
polyp, there will be a cervical rim. There will be a cervical rim around the polyp, ma'am.
And a chronic inversion of the uterus?
Ma'am, for chronic inversion, ma'am, there will be a history of ma'am,
What will it look?
uterus cervical length will be normal.
Yeah, when you do a sounding, it will not go in, and you can see the whole rim, and it is a very violaceous, congested, with a strangulating rim all around it.
Yes, ma'am.
Anu, Karishma?
Okay. So, Vasundhara, you've done very well till now. You mentioned that you did a POPQ for this patient. Can you tell me the advantages and disadvantages of POPQ? That is one question. And the second is, what are the other classifications?
Ma'am, the pelvic organ prolapse is a quantification system. Basically, the major disadvantage is that, ma'am, it is a technical, ma'am, basically it's difficult to understand for some, and then they
Okay, advantages. Tell us
what are the advantages?
Ma'am, we take the hymen as the reference, and there are 9 points. Based on that, if we quantify the leading point, it gives us the idea about the ma'am, it gives us the idea about the basically the ma'am, it gives idea about what we are going to do further for the management, ma'am. It's better for the management.
Dr. Anupma is asking, what are the advantages?
Ma'am, because it is a standardized quantification.
Yes, it's a very standardized format, and you have measurements which are, measured by a tape. So 1 centimeter for you is the same as 1 centimeter for me, as for Karishma and Anupma. So we can compare across board our measurements, and we can ask post-operatively also compare the results. But of course, it's a little time consuming and a little cumbersome and difficult to sort of pick it up. And there was this study where they found almost 60% of the gynecologists responded that they don't use the POPQ, if I'm not right. Karishma, correct me. They said because it is too time consuming and difficult to this thing. So now, Karishma, can you just take us over the POPQ, the points?
Vasundhara, you've done the POPQ in this patient. Do you think this POPQ is correct?
Ma'am, I was not sure about the D point.
Yeah. So let us just go through what the POPQ point.
Actually, wherever okay, ma'am, I will start from the POPQ. What I have read, ma'am, what I have understood, ma'am, the POPQ in the POPQ we take hymen as the reference point. Then there are 2 points taken on the anterior vaginal wall and 2 points taken on the posterior vaginal wall. It has 2 fixed points, that is the A anterior and the A posterior, which is between -3 to +3. Ma'am, anything higher means inside, above the hymen is in minus. Anything which is coming out of the hymen is taken as plus grading. A anterior is the point which is -3, which is 3 centimeter from the urethral meatus inside and on the anterior vaginal wall. B anterior is taken as the most dependent point on the prolapse. B anterior is the most dependent point on the prolapsed bulge. C is the ma'am, in case of hysterectomy, we take vaginal cuff as the C point, while in case of a patient having uterus intact, we take the leading edge of the cervix. Somewhere it is written also that we take the anterior lip of the cervix at the C point.
It's not the anterior lip, because in some patients you will see that the posterior lip is enlarged.
Yes,
so you will
posterior lip is more, yes, ma'am. Then there are 3 measurements, that is the genital hiatus, the perineal body, and the
कि A point क्या represent करता है? What does it represent?
Ma'am, A
Answer
point
Dr. Geeta's question that she was trying to ask you.
uretrovesical angle, ma'am.
Yes.
Uretrovesical junction.
It represents the bladder neck.
Yes, ma'am.
So whenever you're looking for urethral hypermobility and these things, if it is +3, till you reposit this point back, you will not be able to answer her question. So in such patients who have the A point prolapsing out, you have to reposit it to look at urethral hypermobility.
Yes, ma'am.
Then your points GH, PB, and TVL are fixed points. We know genital height is perineal body and total vaginal length.
Yes, ma'am.
AP and BP are similar to BA and A and BA. जो हमने
Yes,
annual report में देखे.
The AP is the fixed point and the BP is the variable point on the posterior wall.
What is D point?
Ma'am, what I read and understood was that it was given that D point, the TVL and the D point are same. It's just that the D point is posterior fornix, like it is more plus minus 1.5 to 2 centimeter than the TVL. Plus, in the case of hysterectomy, we don't consider the hysterectomized patient. We don't consider the D point.
Now let us understand what is D point. Then you will understand why we don't consider it in a hysterectomized patient.
Yes, ma'am.
D point denotes the point where the uterosacral ligaments attach to the uterus.
Yes, ma'am.
ठीक है? तो जब hysterectomy हो गई तो C और D point same हो गए ना, because आपने uterosacral को vault के साथ बांध दिया.
जी ma'am. Yes.
So there is no point considering C and D point separately.
Yes, ma'am.
Now, if you look at, how do you take all these points in resting or in straining position?
Ma'am, a straining position, AA, BA, C in straining position, GH, PB and TVL in reduce, we will reduce, and then AP and BP in straining position and D in resting position.
No. All these points are taken in straining position except TVL. TVL is the only single point which is taken in the resting position. Okay. But all other points, there is no confusion.
Yes. Anupma, Vasundhara, supposing I say, how will you distinguish between an infravaginal elongation of the cervix and versus a prolapse, a cervix coming out? Can you look at this measurement and see which
D equals to TVL?
Whether there is
D.
Yes, C and D. So if it is more than 4, that means there is a protrusion of just the cervix, right?
Yes, ma'am.
We have only 15 minutes. Let's go to the management.
One little point, I'm sorry, because this prop Q is wrong, and again we will do the same mistake. So if you look at the prop Q, your D point is -10, your TV is 8, and C is +6. If you look at the calculation, total vaginal length is 16 centimeter, and then you're writing 8 centimeters there.
Yes, ma'am.
So that can't be possible.
That is not possible. This is a gross error in prop Q.
Yes, ma'am.
So there is some calculation. You have not taken the D point correctly, or you have not taken the C point correctly, or you have not measured the TVL correctly.
Okay, ma'am.
What it looks like, Vasundhara, that if your C is +6, then your D is also practically halfway down the vagina.
Cannot be at -10. And you have said that there is an enterocele in your patient in the palpation and perspeculum. अगर enterocele होगा तो D -10 पे हो ही नहीं सकता.
Yes, ma'am.
So that is why this D also represents pulsion enterocele. If you look at the original paper of PopQ, you will see that wherever enterocele is there, they write it along with the D point.
Yes, ma'am.
So this PopQ is incorrect.
Dr. Anu had asked you about the old one. So there is a Shaw classification, Baden-Walker halfway classification of prolapse. So sometimes the examiner may also ask about this.
And even the supports of the uterus you have to know, because now the time is short. So I think we'll have to move on to the management.
Management, yeah. So quickly, can you tell us now, since we don't have much time, 13 minutes, let's talk about managing this patient and not nulliparous prolapses, patient wanting to preserve the uterus, etc., etc. So you have investigated this patient. She has a thick endometrium. Otherwise, all is fine. Blood pressure is controlled. can you take us over the steps of hysterectomy, vaginal hysterectomy? And there is a thick endometrium, I'm telling you.
Ma'am, firstly, ma'am,
You have investigated her, PAC is fit. She's under anesthesia. Tell me the steps.
Pre-op investigations have been done already, ma'am.
Yes,
Pre-op
ma'am.
has been done, consent has been taken. Blood has been arranged. Patient is on the table and you are the operating surgeon.
Ma'am,
Just like Anupma would do. You don't have to worry when Anupma is there working it.
Ma'am, firstly,
आज भी आप ही की student हूँ मैं.
चलो वसु, पेशेंट अंडर है आपके पास, अब क्या करोगे? She has a thickened ET. You haven't asked me.
I will do a DNC and I will send a frozen to rule out because she has a thickened ET, so I should rule out any endometrial CA or any endometrial hyperplasia with ATP.
Good. So always sample. The moral of the question was that you must sample the endometrium, and in case you have a decubitus ulcer, make it a habit to
pack the vagina by acrylflavin and glycerin. Admit the patient and pack her before surgery one.
Yeah, that has to be healed prior to taking her up on the OT table. And you don't say DNC.
Yes, ma'am. The endometrial sampling and frozen set.
Yeah.
Can you go over the steps of the vaginal hysterectomy for us?
Ma'am, firstly, anterior lip of the cervix is caught with a valsellum, and a 3-point triangle has to be made. Like we will take 2 Ellis marker and valsellum, and the anterior lip of the cervix is caught. Posterior lip can also be caught with another valsellum. Then 2 Ellis forceps are applied. Ma'am, one on a 3 o'clock position and another on a 9 o'clock position. Then, ma'am, and one below the 2.5 centimeters below the urethral meatus. Before that, ma'am, in our hospital we do bladder sounding also to know the exact upper extent. Then, ma'am, a circular inverted T incision, is or a circular incision is given on the vaginal mucosa at the cervico-vaginal junction. Then the vaginal mucosa, ma'am, is dissected of the cervix all around. The cervix is pulled down by the valsellum. Then we mobilize the bladder, ma'am, the cervical ligament. We take a gauze piece, and with the gauze piece and thumb, we try to mobilize the bladder. Then, ma'am, by sharp and blunt dissection, the lateral flaps are created, and the fascia is dissected. Maximum fascia is dissected to strengthen the bladder buttressing process, and then the redundant vaginal mucosa is cut. The fascia is plicated, and the redundant mucosa is cut. The remaining fascia is, ma'am, the remaining.
Fine. You are relax. आराम से बताओ. You have raised the flaps.
Yes, ma'am.
So then, once you have raised the flaps, now would you proceed with the hysterectomy? How do you proceed with the hysterectomy?
Then, ma'am, we will the posterior lip of the cervix is lifted up with the valsellum. The incision on the posterior vagina is given. Ma'am, the posterior vaginal wall is mobilized from the cervix till pouch of Douglas is reached. The peritoneum of the pouch of Douglas is incised, ma'am. Then after that, the Sims speculum is inserted into the opened pouch of Douglas. Then, the utrovesical pouch is opened by taking with the finger and the gauze piece. And then, ma'am, we reach the fundus. We exteriorate the uterus, ma'am. Basically, we reach the fundus with our fingers. We try to
hook it out.
Yes, ma'am. Then we start with the clamping. Firstly, the clamping of the uterosacral and the Mackenroth ligament. Then we cut it. Then the pedicle is sutured and transfixed. Then, ma'am, we proceed to the uterine vessels. We cut it, and then we clamp it. Then cut it.
So
then
you remove the uterus. Uterus is out.
Yes, ma'am.
Do
Then, ma'am, we do the Macal. हाँ जी, ma'am.
you have done the hysterectomy and you managed to remove the tubes, ovaries also from vaginal. This thing. Now, then what do?
Ma'am, basically to prevent wall prolapse or enteroceal, it should be a mandate that we do the Macal scaldoplasty also with the vagina.
So Macal scaldoplasty will is the answer to wall prolapse?
No, ma'am. It is
the answer to the end because your patient has a big enteroceal. Na?
Yes, ma'am.
Then what else? Next
Then,
step.
Just tell us internal and external.
Perineoplasty.
Vasundhara, please tell us internal and external Macals.
Ma'am, in Macal scaldoplasty, basically we take a vital suture and it is passed through the post. Ma'am, we take the pedicle of the uterosacral ligament and of both the sides. Our main motive is we want to approximate the uterosacral ligaments and we want to lift the vault with it. And we in internal we do it internally, while in external we pass the the vault, then the uterosacral ligament, and then the vaginal mucosa, and then we try it at the end. Like
what mucosa? Sorry, what did you say?
Ma'am, the flap which was left, basically we have to externally we have to tie it, ma'am.
No. What are the bites you will take? External Macals, you will take the vaginal mucosa, then you'll come peritoneum, other uterosacral, and out
yes,
of
and the out. Yes, ma'am.
Then this you will hold long and tie last.
Tie last.
And even the uterosacral, you can tie one thread together and the other thread you can take it on a needle and take it out through the lateral vaginal angles, and this also hold long and tie last.
Yes, ma'am.
Keep open, and meanwhile you do the Macal scaldoplasty and do the anterior colpography
and posterior colpoperineal.
What are the points in favor of? How will you make sure that your is all right? Your anterior colpography. What are the things you will take care of?
What, ma'am?
Whilst you are doing the anterior colpography,
yes, ma'am.
What are the things you should take care?
Ma'am, bladder should be, ma'am, bladder should be away. Like we will take a retractor and we will retract the bladder away. Then the maximum plication of the plication of the redundant vaginal mucosa has to be done. And ma'am, after doing the anterior repair, we have to do the Foley's catheterization to see for the drainage of the urine, ma'am.
Right. Then
any injury to bladder or yes, ma'am. Then we will proceed with posterior.
No, you have done the catheterization, na? You said that. Now supposing blood is coming out, you put a catheter and blood has come out.
Yes, ma'am.
What will you do next?
Ma'am, then we will do a laparoscopic. Ma'am, we will call
catheter.
If it is, ma'am, it depends on the blood. It depends basically on the color, ma'am. Whether it is blood tinged, what is the hematuria? Like if it is blood tinged, because we are fiddling and we are handling the bladder a lot, then it might happen that there can be a blood stained urine, ma'am.
Yeah, you may have, whilst you are pushing the bladder away, you may have injured the bladder. And you know that area is very near the trigone, the uretrovesical junction is right there. Then you may have taken a deep bite while doing the plication. So you will do an immediate cystoscopy. Am I right, Karishma?
Yes, ma'am, we can do that. If we are suspecting any kind of interference with the bladder, it's always good to check right there and then.
Right. So I think at the PG level, they should just be able to answer that. Itna hi bol de, wahi bahut hai. Ki bladder mein dala, blood nikla, and you do cystoscopy and determine the cause. And now come to the posterior colpoperineography. How will you do that?
Ma'am, now we will proceed with the posterior colpoperineography. basically we will take the ma'am with the Ellie's marker on the mucocutaneous junction. We will make a horizontal incision, and then we will start ma'am same as like we will give a horizontal, then a vertical incision, and then we will retract, make a flaps. Then we will placate the fascias, try to cut the redundant mucosa, and then we will.
Telant says sometimes you can give a circular, in the rectovaginal fascia, Telant says that you can do a circular rectovaginal fascia application. You can do vertical or a purse string suture there. Now, so you have patient you have finished the prolapse repair very nicely. You are very happy. Catheter you have put, it is clear urine, and you have put a pack. Okay. Now you put a pack, and next day patient, you find that the patient is very pale. The pack is fully soaked with blood. How will you manage? What do you think has happened?
For an transvaginal scan for a pelvic hematoma or collection.
Yes. So what is the incidence of pelvic hematoma collection in an abdominal hysterectomy versus vaginal hysterectomy? There are numerous studies, and you tell us their findings. Which is more likely to have a collection, post-vaginal or post-abdominal?
Ma'am, I haven't read it.
Okay, so post-vaginal, there is a higher chance of vault collection. How much? They say roughly 40 to 60 ml is quite a normal collection which you can have. So now this patient, you have removed the catheter after 3 days, and she's unable to pass urine. She's gone into retention urine. How will you manage?
Ma'am, we will recatheterize her.
1 liter urine has come out.
Ma'am,
in other words, I'm asking you management of retention of urine in a post-operative vaginal hysterectomy case. There are standard protocols given by Dr. Ajay Rane. How will you do it?
Ma'am, we will recatheterize the patient. We can go for an ultrasound post-voidal residual urine. Then, ma'am, we will start.
You have catheterized the patient, so how will you measure post-void residual? You have already catheterized. That is what has given you the post-void residual is in your hand. 1 liter. I'm telling you 1 liter is the post-void residual. Now, what will you suspect? 3rd day, you have removed the catheter. She was unable to pass. What will you do? Will you do a PV or not?
Yes, ma'am.
What are the causes of post-op retention of urine?
Ma'am, there can be hematoma or a pelvic collection pressing the bladder. Ma'am, then, ma'am.
Pain?
Common causes, Vasundhara.
Ma'am, if you are we are using any cautery injury, pain can be there. Then, ma'am, any injury to the pipe.
Pain, constipation.
Yes, ma'am. Ma'am, pain, constipation, pain can be because of hematoma.
UTI.
Yes, ma'am.
So these are the causes you will try to rule out and ensure that the patient, these causes are taken care of. You'll obviously get a scan done to look for any collection, examination to look for collection. 3rd day, it may not be easy to examine the patient because she's going to be painful. You may not be able to see much. You can do a per rectal to see if there's a collection somewhere there. Because vaginally, it will be very difficult to examine her on 3rd day.
Right. So I think we've finished our
Last
time.
question. One last
yes, Anu.
question.
Yes.
What
Anu.
is ward Mayo's surgery, Vasundhara? You've done very well. You've answered practically everything. You tell us what is ward Mayo's surgery.
Ward Mayo's is, ma'am, same vaginal hysterectomy with pelvic floor repair.
Okay. She's done a good job.
Yes, I think she's done a good job. And I think Dr. Karishma and Dr. Anu, has been a real pleasure having you.
Thank you.
Honestly, I have also learned a lot interacting, and I hand over the session to Dr. Bibhushan to continue.
Thank you, ma'am.
Thank you, ma'am.
Thank you, everybody.
Thank you, Dr. Karishma.
Thank you, ma'am.
Thank you, ma'am, for the detailed enlightenment on uterovaginal prolapse and related issues. Now we move further. The next session, we will be dealing about hypertensive disease disorders in pregnancy. The moderator for the program, Dr. Poonam Lal. She is a senior specialist from DDO Hospital, New Delhi, with special interest in infertility and HIREX. Also, we have Dr. Manisha. Ma'am is Director Professor and LM Lady Hardinge Medical College, with and our presenter for today's program, Dr. Smriti, second year primary DNB trainee, and Dr. Khadija, first year secondary DNB trainee. So I hand over to both of them, Smriti and Dr. Khadija, for further, ma'am.
Good afternoon, ma'am. My case is
Smriti, are you starting?
yes, sir. Mrs. X, 30-year-old female, resident of Mayur Vihar, Delhi, housemaker by occupation, educated till class 12, belonged to the upper middle socio-economic class according to the modified Kupu-Swami scale, married since 6 years, non-consensus marriage, G3P1L1 A1. Her last LMP is 29-22. Expected date of delivery is 27/6/23.
Next slide. Okay, move on to the next slide, Smriti.
Ma'am, we will share again.
Best fried rice paneer. एक best fried rice paneer. Check करने.
Presented with 8th month of amenorrhea and came for routine ANC visit, and where her blood pressure was found to be high. It is around 140/90. Patient came to the antenatal OPD for routine checkup at 8th month of amenorrhea. Her blood pressure was came to be high according to the patient as told by the doctor, and she was advised admission for further evaluation and monitoring. There is no history of headache, blurring of vision, epigastric pain, or right upper quadrant pain. No history of vomiting, no history of chest pain, breathlessness on exertion, palpitation. No history of decreased urine output. No history of swelling of feet, excessive weight gain. No history of pain, abdomen, leaking per vaginum, or bleeding per vaginum. In her first trimester, there is spontaneous conception. UPT was done at home when patient was 15 days overdue, which was positive. She visited Sir Gangaram Hospital at 2 months of period of gestation, advised routine antenatal investigations and ultrasound dating. That came out to be normal. Advised one yellow tablet once daily as told by the patient, took regularly. No history of excessive nausea and vomiting. No history of fever with rash, burning, micturition. No history of bleeding per vaginum, discharge per vaginum. No history of drug or any radiation exposure. In the second trimester, tweaking at 5 months of amenorrhea, booked at Ganga Hospital and immunized against tetanus at 4 and 5th month. Level 2 scan was done at 5th month, that came out to be normal. History of regular intake of iron, folic acid and calcium once daily. No history of high blood pressure recording, epigastric pain, blurring of vision, headache, decreased urine output, swelling of feet. No history of excessive hunger, thirst, frequency of urination, recurrent urinary tract infection. No history of easy fatigability, dyspnea on exertion, palpitation, chest pain, clinical attack. No history of fever, bleeding, or leaking per vagina. Patient continues to, in the third trimester, patient continues to perceive adequate fetal movement. There is a history of iron and calcium intake regularly. No history of leaking, bleeding per vagina. No history of excessive thirst, hunger or urination. Ultrasound growth scan was done at 7 months, to be normal. On her second visit in the third trimester at 8th month of amenorrhea, she came to antenatal OPD for routine. Her blood pressure was taken, which seemed to be high as told by the doctor, and was advised for admission for further monitoring and evaluation. Patient did not have any complaint of nausea, vomiting, headache, blurring of vision, epigastric pain, or right upper quadrant pain, and swelling of teeth. Her menarche, in the menstrual history, her menarche attained at the age of 14. And her last menstrual period is 29-22. Her expected date of delivery is 27/6/23, and the period of gestation is 24. It is previous menstrual cycle was regular, occurring at 28 days interval and lasting for 5 days, with average flow and soaking 2 pads per day. In of history, married since 6 years ago, non-consensual marriage, G3P1 L1A1. Her abortion at 5-year wax, spontaneous abortion. For that, DNC was done. In 4-year baby girl, full-term vaginal delivery. The birth weight of the baby is 2.6 kg. History in the previous pregnancy, history of high BP records near term, treated with antihypertensive. Intrapartum and postpartum was uneventful. Child exclusively breastfeed for 6 months. The child has normal milestone, immunized according to the national immunization schedule. G3 is the present pregnancy and it is a spontaneous conception. There is patient was using barrier method of contraception on and off. In the past history of hypothyroidism since 3 years, control on Tylenol 50 microgram per day, not a known case of diabetes, hypertension, heart disease, systemic lupus erythematosus, renal disorder or asthma, no history of tuberculosis in the past. In the personal history, regular normal sleep pattern, she is non-smoker, non-alcoholic, no history of drug abuse, no bladder and bowel complaint, no known allergies. In the family history of hypertension in the mother, diagnosed 10 years back, control on oral medication. In the diet history, she consumed mixed diet, calorie intake to 2,600 kilocalorie per day, and protein intake is 6 grams per day according to the 24 recall method, which is adequate. In the socioeconomic history, she belonged to the upper middle class according to the modified Kukuswamy scale.
Examination, general physical examination. Patient sitting comfortably. Patient is conscious, cooperative, well oriented to time, place, and person. Average build and well nourished. General condition is fair. Height is 155 centimeter. Weight is 60 kg. Pre-pregnancy weight is 50 kg and BMI is 20.8. On head-to-toe examination, hydration is adequate. Hair showing more normal texture. No pallor, icterus, cyanosis, clubbing. No glossitis. Orogenital hygiene is maintained. No palpable lymphadenopathy or thyroid enlargement. GVP is not raised. Breast showing normal changes of pregnancy. No inverted nipples. And grade 2 pedal edema seen. Then vitals, temperature 98.6 degree Fahrenheit. Pulse rate is 88, taken in the radial artery, good volume, regular, no radial or radiofemoral delay, all peripheral pulses felt, all the peripheral pulses palpable, SpO2 98% on Trumer, BP in the right arm is 150 by 94, and in the left arm is 152 by 92 in the sitting position. Our respiratory rate is 16 per minute, thoraco-abdominal. On systemic examination, respiratory system bilateral air entry present and equal. Serious apex beat in fourth intercostal space in left anterior axillary line. S1, S2 normal and no murmur here. CNS, all reflexes normal. On abdominal examination on inspection, abdomen is uniformly distended, no abdominal wall edema, uterine ovoid in longitudinal axis, umbilicus is central and everted, linea nigra and stria gravidarum present, all quadrants moving equally with respiration, all hernial sites are free, no dilated veins or scar mark. On palpation, local temperature is not raised, no organomegaly, uterus corresponding to 34 weeks size, relaxed, dextro-rotated, symphysiofundal height is 34 centimeter and abdominal girth 80. Uterus is relaxed and non-tender. On fundal grip, soft, broad, and irregular, non-palatable podalic end was palpable at fundus. On left, lateral grip, smooth, curved part suggestive of back. On right lateral grip, soft, knobby part suggestive of lymph. First pelvic grip, smooth, hard, globular, palatable part suggestive of head. And deep pelvic grip converging suggestive of head is not engaged. Liker appears clinically adequate and expected fetal weight 1.5 to 1.8 kg. Auscultation apertures heard along the left spino-umbilical line, 140 beats per minute and regular. Local examination, no bleeding per vaginum, PSPV not done. So, my patient is Mrs. X, a 32-year-old female, third gravida, parent, and abortion 1 at 34 plus 3 weeks period of gestation. Is it? It's a case of a hypertension. It's a case of a hypertensive disorder of pregnancy like gestation hypertension with a single fetus in longitudinal line, cephalic presentation not in labor.
Okay. Done with the history?
Yes, ma'am.
Okay. Let's start from your original diagnosis only.
Yes, ma'am.
How can you say that she is a case of hypertensive disorders of pregnancy, most likely gestational hypertension?
Ma'am, her BP is more than 140 by 90 and there is no proteinuria and it is diagnosed after 20 weeks of POG, so we can say that it's a gestational hypertension.
But did you mention about the protein investigations? You have just examined the patient, no?
Yes, ma'am. Yeah.
Okay. This is the later on, na?
Yes, ma'am. After admission.
After admission, but you haven't shown us the slide of investigation. Na? Now you are showing.
Yes, ma'am.
So in the exam, when the examiner will be telling you to take the history, suppose the investigations are not given, and just from the history and examination, what will be your diagnosis? You have not investigated the patient as yet.
Sorry, ma'am, I didn't get the question.
You have not you have done no investigation. You are not given any investigations in hand. Okay.
Yes,
just her BP is high. Would you like to change your diagnosis? That
if BP is more than 160, systolic or diastolic is more than 110, then it can be severe.
Ma'am, it may be the
preeclampsia.
No, talk about your patient, this patient. What is it? What is this patient based on the history and clinical examination? This is what
there may be the white coat hypertension or mask hypertension.
Okay. So what would you do to be sure that it is gestational hypertension?
Ma'am, we measure the BP in two occasions after 4 hours apart. Then we found that there is a increase in the recording of the BP. Then it is after 20 weeks of period of gestation. And in the white coat hypertension, the BP in the hospital, it is BP recording is high, but in the home there is no high recording of the.
Yes, okay. So you will repeat it after 4 hours. You wanted to say this.
Yes, ma'am. Yes, ma'am.
Dr. Poonam, you want to continue?
Okay, suppose if, thank you, Dr. Manisha. Suppose after 4 hours also the BP is high. Okay, and urinary albumin is negative. What is your diagnosis? Urine for protein is.
Ma'am, we investigate investigate CBC and LFT and see the end organ damage. If it is normal, then we diagnose the gestational hypertension. And if there is delay in any value of the platelets count and LFT, KFT, and any signs of the end organ damage, then we consider as preeclampsia with severe symptoms. Without
Okay. Okay. What would you like to, which investigation would you like to do? Smriti, can you keep the this microphone near your face, because you are not very much audible.
Okay, ma'am. Ma'am, we first of all we give the CBC with peripheral smear. In CBC, we do the.
Liti, always try to give full form. Don't give abbreviations, okay? In the exam also. So it is complete blood count, you can say, rather than CBC. Yeah, continue.
Smriti, are you there? I think they are having some connectivity problem. Are you there, Smriti? Dr. Manisha, can you hear me?
Yeah, I'm able to hear you, but the voice, like other people have also written in the chat that
audio is not clear. Yeah. I think there is some connectivity problem. Smriti, if you can hear me, can I point out some things in the history? Hello? One thing is when you're speaking LMP and ED, this expected date of delivery, you say 20th September 2022, 29 2022, that doesn't seem very nice. And but when you say this modified Kupuswami, you should be able to differentiate what is actual Kupuswami and what is modified Kupuswami. Some examiners ask this. Then you have written date of UPT. It will be preferable if you write the date of UPT, that she said she was 15 days overdue. If she remembers that account, it will be better. Then recurrent UTI you have written in the history. Patient doesn't know what is recurrent UTI is. You have written the symptoms. So I think that is sufficient. Then you have asked the history of asthma in this medical history. May I know the significance of asking for a history of asthma? Though it is there, but you should be knowing it. And you have written no peripheral pulses are normally palpable. Which peripheral pulses did you see? Examiner might ask. And reflexes, you said in CNS all the reflexes were normal. So I would like to know which reflexes did you test? And you have all in the end you have written all hernial sites are free. You should write hernial sites are free on cuff impulse. No cuff impulse on any of the hernial site, because on lying down all the hernial sites will be free unless either the patient gets up or puts some intra-abdominal pressure increases or there is cuff impulse. So you have to write all hernial sites are free at cuff impulse.
Okay.
Now you can continue. Dr. Manisha, you want to ask something? Because I think I am not audible to them.
Okay. So first of all, you just tell me, how do you take a BP? How should the BP be measured and what is important in blood pressure?
Ma'am, BP should be measured in the semi-recumbent position. In the left arm, the cuff should be covered the 1.5.
Patient must be seated with the feet supported for 2 to 3
Yeah,
minutes.
so we should be clear that it should be sitting position and not semi-recumbent. And one more thing
The
you
first
said.
antenatal visit should be measured on both the arms, and thereafter, if there is no any significant difference, then we can continue with the right arm. And if we are and left lateral recumbent position is preferred in the bed-bound mother.
No, it is sitting. It is sitting. The recent whatever recommendation is, and they say that it should be sitting. The legs should not be crossed. So you should know the ideal condition that the machine should be at the level of the heart, and the cuff should be of appropriate size. Patient should be relaxed. Hand should be rested. So you should know all this because the BP will vary. And how should be the machine be? Whether it should be automated machine or it should be manual.
Mercury sphygmomanometer is the gold standard for blood pressure measurement.
One of you speak, otherwise we are not able to understand.
The mercury sphygmomanometer is the gold standard for the blood pressure measurement according to Foxy guidelines.
No, so we should not stick to the Foxy guidelines, I think, because we should look for other guidelines, whatever is there in like the RCOG and the FIGO also. So it is actually the automated machine which is preferred, and it should be calibrated. So you can mention that it should be calibrated from time to time, and it should be an automated machine because you cannot calibrate a human being. So it should be automated machine which is calibrated. And ideally it should be taken in both the arms. We can take in one arm also, wait for 5 minutes, take another in the same arm. That will also do. So that is the ideal method that is acceptable under international standards. Okay.
And
so,
no tobacco and caffeine half an hour
No
before.
tobacco and
Yes.
caffeine consumption before 30 minutes.
Yeah. So suppose in the first trimester, if this patient would have come, what screening test we could have done in this patient?
In the first trimester,
Ma'am, for the screening for preeclampsia,
There would be some clinical factors that we would look for.
ma'am, we will ask about any history of whether the patient is at risk of developing preeclampsia or not. At every antenatal visit, we will check that whether she is at a high risk for developing preeclampsia or not. We'll ask about if there is any history of previous hypertension or any history of hypertension in family. We will check her BMI. If it is more than 30, then she has risk.
Hypertension, 1 minute. Hypertension in family is not there in the risk factor. Mother having preeclampsia is the risk factor. So are all risk factors same, or they are divided into major and
NICE guidelines are divided into the moderate and high risk factors. Moderate risk factors are nulliparity, age more than 40 years of age. If the interpregnancy interval is more than 10 years.
Okay, so we are running short of time, so we will proceed further. So if you find this patient to be at high risk, what treatment you can give to this patient?
When we start with the low dose aspirin.
One of you speak, yeah. So what is the dose of aspirin?
75 to 150 milligram.
75 to 150 is a quite a large range.
150 milligram once daily.
So it can also be given as 100 if the patient is of low weight. So, but it is 150 ideally. Is there a particular time in which we give?
At the bedtime, ma'am.
At bedtime. And when should we start?
Ma'am, it should be started at 12 weeks.
After 12 weeks, 12 to...
Ma'am, it should be started at 12 weeks.
It should be started before 16 weeks. Do you know why it should be started before 16 weeks?
Because of placental implantation occur at the start at 12 weeks.
Implantation. Is it the right word?
No,
The second wave of trophoblastic invasion. The second wave into the muscularis takes place around 12 to 16 weeks. Okay, so if you have done proteinuria of this patient, you want to test what are the ways by which you can say that this patient is having significant proteinuria?
We can send a urine protein creatinine ratio if it is more than or equal to 0.3. Then we can say that our 24-hour urine protein is more than 300 milligram, or urine albumin creatinine ratio is more than 8, and at least 2 plus on dipstick reading.
Okay. And so can you just enumerate what would be the complications of hypertension in pregnancy or preeclampsia, maternal and fetal?
My mother, maybe in fetus there can be FGR or fetal growth.
Always start with mother. That is the best thing. No, examiner also likes to hear.
Ma'am, in mother, there may be, ma'am, there may be the eclampsia, abruptio placenta, and chances of the eclampsia in the future pregnancy may be high, and preterm delivery, and liver.
Yeah, one of you should answer. One of you should answer about mother's complication. The other one can prepare for the fetal complication. It is not a combined viva. In exam, you are not supposed to give combined viva.
Ma'am, in mother, there is a risk of eclampsia, placental abruption, preterm.
Yes.
Preterm
Start with more common ones first. HELP syndrome. You can start with that first. Okay. So if it is preeclampsia, then preeclampsia it can be HELP syndrome. And then you can go on to talk about other complications. Is diabetes associated with preeclampsia?
Yes, ma'am.
So you have to mention that too. Okay. So can we talk about fetal ones?
Let's hear, Dr. Manisha, let's hear about all the maternal complications first.
Okay.
Preeti, you speak. You have told eclampsia, HELP syndrome, and third one you told, which one?
Pulmonary edema, ma'am, acute renal failure.
Pulmonary edema, acute renal failure, right? What else?
Then retinal detachment.
Retinal detachment, very good. What else?
Stroke.
Stroke, yes, very good. What else?
Abruption.
Abruption, okay. What else? Huh? What did you say? You are right. Please repeat.
Cerebrovascular accidents.
CVS, yes. Cerebrovascular accidents. What else?
Heart failure.
Heart failure, yes. What else?
DIC, ma'am.
DIC, very good. What else?
Ma'am, done.
Can there be done? Can there be spontaneous hemorrhage?
Yes, ma'am.
Intra-abdominal.
Abruption.
Abruption तो वो हो गया from liver.
Subcapsular hematoma, ma'am.
Yes, subcapsular hematoma. Sudden blindness.
Neurological, sudden blindness.
Neurological. Yeah. Can there be myocardial ischemia?
Yes, ma'am.
Yes. So you should divide it into neurological, then come down to the retinal eyes complication, then to the respiratory system complication. Can there be ARDS?
Yes, ma'am.
ARDS. And then come to the heart complication, lungs complication, then liver, then to the kidneys, and then to the hematological DIC and the DIC also you have not spoken. You told? Okay, okay then. So there are 12, 13 complications. Now, Smriti, can you enumerate the fetal complications?
Ma'am, in fetal complication, there is a fetal growth restriction, FGR, oligohydramnios, preterm delivery, and the chances of, in the preterm delivery, there may be the chances of the respiratory distress syndrome, intraventricular hemorrhage, necrotic enterocolitis, and there may be the chance of the stillbirth. In the long term, there may be the chance of neurological deficit, cerebral palsy, and cardiovascular disease.
Okay. Dr. Manisha?
Yes.
Yeah,
So,
you may ask the next question.
Yes. So we will talk about when we talk about preeclampsia, are all preeclampsia same? There are certain severe ones, severe preeclampsia, and does it make a difference in the management?
Yes, ma'am. There are two type of preeclampsia without severe feature and preeclampsia with severe feature. In preeclampsia without severe feature, the BP is more than 140/90, and after 20 weeks of gestation with proteinuria. In the preeclampsia without and organ damage. In preeclampsia with severe feature, there is the BP is more than and equal to 140/90 or 2.
Okay, so what is the basic difference in management? If you get a preeclampsia with doesn't have severe features, what all can you do in that patient? Starting from what conservative management would you like to give? Would you like to admit that patient, or can you send her home?
Ma'am, in the
Suppose like your patient at 34 weeks, this patient at 34 weeks is having preeclampsia. We did the investigation, urine proteinuria was there, and we came to know at 34 weeks that she is preeclampsia, but her BP is, like you said, it is not in the severe range. Now, how are you going to manage this patient?
Ma'am, we do not admit this patient to the hospital, and at least 48 hours again we repeat the BP and check if BP recording it is high or low, and then
But you have not done any investigation. So you have to say that you can admit her for some time, or maybe you will get the investigations. So if the investigations also doesn't show any other end organ damage, then only you will label her as. So just BP will not be suffice, hai na? So you can get all investigations done, and then if she is comes out okay in those investigations, then you can ask her to go home. How frequently you would like to see her again?
Ma'am, every 48 hours.
Every 48 hours she will come to you?
No, ma'am. Twice a week.
हाँ, every 48 hours तो बेटा बीपी नहीं भी बढ़ा होगा तब भी बढ़ जाएगा. इतने ट्रैफिक में आएगी, लाइन में लगेगी.
So you can call her twice a week, that is okay, or depending upon. So she is 34 weeks. And so do you think, what is the progress like? In preeclampsia, does it progresses slowly, or it can progress anytime?
Ma'am, it progress at any time.
So it can progress at any time. So so then in your patient, she is already 34.
Yes, ma'am.
Can you do some other investigations also in this patient to understand whether she is going to have, whether she is safe for 1 or 2 weeks or not?
Ma'am, ultrasound for fetal valving and the Doppler.
Very good. Anything else?
Ma'am, CTG monitoring.
Okay.
What else?
Ma'am, baseline investigation, liver and the kidney function test and the.
Have you heard something about biomarkers, FLIT and PLGF?
Yes, ma'am.
So can you do it here?
Ma'am, that are done in the first trimester and the second trimester.
No. To see the progression also, you can do.
Okay.
The SFLT PLGF you can do to understand whether you can really send this patient home or not. Otherwise, of course, if you have admitted this patient, found that it is okay, you can just leave her and ask her to go, but then you have to be very vigilant. Now, suppose your patient is having severe symptoms at 34 weeks. Maybe she's having impending eclampsia. What are you going to do? Like headache, blurring. Why does headache occur in a patient of severe preeclampsia? What is the reason for headache? Persistent headache.
And because of cerebral edema.
Okay. What else?
There is actually hypoperfusion that leads to that headache. And edema, of course, is there. What is the main site of edema?
Occipital and lateral ventricular.
Okay, so suppose this patient has a very high BP and she falls into your severe preeclampsia category. What are you going to do? How are you going to manage?
She comes with the preeclampsia with severe features, then we will give her a Maxel loading dose, will control her BP, and if it is not controllable, then we can go ahead with the termination of pregnancy.
She's 34 weeks and you want to
Headache.
control her BP. How are you going to control her blood pressure? Her blood pressure was 160 by 112. You repeated it twice. After 15 minutes, it was again 65 by say 112.
So, ma'am, we will give her IV labetalol injection.
Okay, how will you give it?
Ma'am, 20 milligram IV we give over 2 minutes. Then we take a BP again in 15 to 20 minutes. If still the BP is 160 to 110, then we can give 40 milligram. Up to 300 milligram, we can maximum dose that can be given is up to 300 milligram.
What will be your target of BP?
Ma'am, if it is 160 by 110, then the target should be like 150, 100, not less than that.
Yeah, so you just bring it below 160 and 110. You don't keep on giving. So you give 20 and then after 10 minutes or 20 minutes, you again give 20 and then if it doesn't get control, you give 40. And so there are different regimes, but generally you start with low 20, 20, 40, you can give up to 300. But then it is not needed. So when once the BP becomes 150 by 100, as you said, what do? You just leave, you don't do anything or you give something? As an anti-hypertensive. You give oral. So you must complete it here. जब भी बोलते हैं emergency labetalol जब बताते हैं तो complete it here till the BP becomes less than particular जो भी 150, 100 या 110, then you give oral. ठीक है? So after this, what are we going to do? You want to do conservative management with this patient?
No, then we can give Maxel.
Yes.
For Maxel loading.
Okay.
And
how much loading you will give?
Corticosteroids for the fetal lung maturity.
She's already 34.
She's already 34 plus 4 weeks. In other words, I think Dr. Manisha wants to ask what are the indications of expectant management and what are the contraindications where you would not like to continue with expectant management.
Ma'am, the indication of the expectant management for the if the fetus and the mother is stable and there is a control of BP and there is non-progressive the routine the investigation that is renal function test and the labor function test, and there is a reassuring fetal heart sound. There is no IUGR and the FGR.
Now this patient is having 160, 112 BP. You have given her labetalol and she is also having headache, persistent headache she is having. So would you like to continue with expectant management or would you like to do something else?
Like to
terminate the pregnancy.
Okay. So how will you terminate the pregnancy?
We'll do the PV and look for the bishop is 4.
And if it is more than 6, then we do
So one thing you have to always remember and tell specifically that I would stabilize the patient. So always say that I will stabilize the patient, then induce. Okay, so this is very important that you stabilize. Don't hurry on delivering a patient before stabilization. So you will always say that I will stabilize the patient, then I will do a PV, and then I will think of what to give for induction. What are the problems? Dr. Poonam, you wanted to ask something? You can ask.
No, Preeti, just tell me how will you assess the bishop? What are the criteria of bishop score testing?
Ma'am, cervical dilatation, position, effacement, and the station, consistency.
So there are how many criteria?
5.
5. Dilatation, position,
consistency, and station or spacement.
Effacement. Suppose our bishop is 6. What will you do?
Ma'am, first of all, we do the stripping, and then we induce the labor with gynoprost, prostaglandin, and then we assess the patient.
Okay, you have given 1 dose of gynoprost. When will you repeat the PV?
Ma'am,
When
then
will
after 6 hours, we repeat the gynoprost. If
Okay.
there is
You have repeated the gynoprost. Okay, 6 hours. You are right. Bishop was not good still, and you have repeated the gynoprost. And you have just inserted the gel, and your junior comes running. Ma'am, patient has thrown a fit.
then ma'am, first of all, we stabilize the patient. We give the Maxel. First of all, we stabilize the patient. We give the tongue depressor and the left lateral position.
Tongue
And
depressor or something else?
Mouth gag.
Mouth gag. So mouth gag can be anything. Okay.
Suction out the secretion.
Okay, what else? So first is you have stabilized the patient. So first thing you have done, you have put a mouth gag. What else will you do?
Ma'am, then we do the suction and then
suction evacuation. You started doing suction and the patient falls from the bed.
Ma'am, we go for the help. Then we
Yes.
first of all we
Side rails.
Side
Call for help. Side
side
rails, mouth gag, or secure the airway. Fourth thing is
secure the breathing, ma'am. O2 mask should be applied, and secure the IV cannula, 16 gauge or 18 gauge cannula, and we give the Maxel loading dose, ma'am.
Would you like to turn the patient to the side?
Yes, ma'am.
We turn the patient to the left.
So you have to speak all these 5 things, na? Stabilize करने का मतलब क्या है? You should be knowing what is stabilization. Okay. Once the patient throws fit, call for help. Shore मचाओ. Immediately. Sister, doctor, patient has thrown a fit. Come here. Second thing is raise the railings, secure the airway, lateral position, and fifth thing is oxygen. Suction नहीं करना शुरू कर देना एकदम. साइड पे करो और फिर उसके बाद 5 चीजें करने के बाद then you have to start अगर suction करना है. Okay. What else then?
Then ma'am will secure the IV line. Check her BP again. Then we'll give the Maxel floating dose, 4 gram IV, and then 5 gram on each buttock intramuscular.
Okay.
Then we'll do the Foley's catheterization also.
Yes, and then while doing Foley's catheterization, what else will you do?
Input output charting.
जब Foley's डाला है तब क्या करोगे?
Urine sample should be sent for.
Foley's जब डाला है तो उसी टाइम PV भी करोगे ना?
Yes, sir.
Maxel दे दिया, Foley's डाला, साथ ही साथ PV करी, जब IV डाला तो साथ साथ investigations निकाली. You have to speak all these things. Okay. Suppose you have given Maxel and you have given 2 gels you have already given. She was all one finger, poor bishop was there, and after 1 hour again she throws fit. What will you do?
Then again we repeat the loading dose of Maxel.
2 grams.
How
much?
2 grams.
2 gram. Yes.
Would you do something else simultaneously? अगर 2 gram और दिया है.
Then we start the maintenance dose at 1 gram per hour.
नहीं, we will take magnesium का levels करा सकते हैं ना? Just to understand, we are giving a higher dose. Okay.
So suppose the magnesium level comes to be 10. Okay, 12. Magnesium level comes to be 12.
So ma'am, it is respiratory depression.
Then we give the
calcium gluconate IV.
How much calcium gluconate? Huh?
10%. 1 gram of calcium gluconate we give over 10 minutes. 1 gram of 10% calcium gluconate IV over 10 minutes. And
10 ml. Just
10
remember 10 ml, 10%, 10
and
minutes.
10 minutes.
Okay. In ACOG, they have written 3 minutes, but for just to remember, you remember these 3 rules of 10. 10%, 10 ml over 10 minutes. What else is to be given for magnesium toxicity? One is calcium gluconate. What else?
Calcium chloride can also be given, ma'am.
Calcium हो गया, calcium chloride, gluconate कुछ भी दिया. Second thing क्या करनी है? What will calcium do to the magnesium? Okay. How will it? How is an antidote to magnesium toxicity? How is it? How does it act?
मैम चेलेट करके and then फिर urinary excretion के through.
हाँ, तो urinary excretion increase करोगे ना, तभी तो वो निकलेगा बाहर में. क्या करना है?
So diuretic देंगे, ma'am.
Diuretic furosemide देना. So you should be speaking this thing in magnesium toxicity, calcium gluconate plus diuretic. Okay. So she has 3 fits she has thrown in the last 1 hour. Cervix is not favorable. What will you do?
Ma'am, we'll take her for cesarean section.
Cesarean section. Okay. What anesthesia would you prefer in cesarean section?
Regional and general anesthesia.
What is the
Regional
problem?
anesthesia.
What is the problem with, like in this case, maybe you would like to give general anesthesia only, na? Patient is having eclampsia. Maybe she's not conscious only. What is the problem with general anesthesia?
Ma'am, during intubation, there is a, we found a problem. There is a laryngeal edema.
They can be spasm and patient can have cardiac arrest. Yes. So regional is better always in a patient who is having preeclampsia or even in eclampsia if she has gained consciousness. So what special precautions do we take while giving anesthesia, regional anesthesia also?
Ma'am,
Would you prefer epidural if there is a choice of epidural or combined? Epidural is preferred, right?
Why, Preeti? Why is epidural preferred? Less chances of hematoma.
Okay.
And in spinal, sudden hypotension is there. So placental separation can occur. Okay. And the other problem with GA is one is laryngeal edema. Pharyngeal edema is there. Difficult intubation. Second is while intubation and extubation, there is lot of fluctuation in BP. So patient can have cerebrovascular accidents. And third problem with GA is you will have to be very quick once you have given GA. You have to be very quick in taking out the baby. So incision to baby out time has to be very short. Okay.
Yes, ma'am.
So you have given anesthesia. What problems can you encounter while doing cesarean in a patient of eclampsia?
And excessive bleeding, postpartum hemorrhage.
Okay.
Case of preeclamptic patient.
Okay. What else?
Why there is postpartum hemorrhage? I mean, why do we say that there's more chances of postpartum hemorrhage?
Because there is a vasoconstriction, the blood supply to the uterus is decreased. That's why there is a chance.
Decrease हो गई ना तो कम होना चाहिए फिर तो.
Ma'am, increase.
Increase क्यों होगा uterus के अंदर? Intravascular blood volume कैसा है? Hemo concentration है? Dilution है? Hemo concentration. So whatever loss is there is multiplied many times. So that is one of the reasons. There would be many other reasons also. There can be prolonged labor. There can be some other, you're doing a preterm section or delivery that would also amount to it. You're giving some centrosanon. All those things account for it. But there is hemo concentration that we must understand. Yes. Any other complication?
Dr. Manisha, can I ask one question?
Yeah.
Dr. Smriti, suppose you have taken the patient for, you have sent the patient for cesarean eclampsia patient. The anesthetist is very angry with you. Why have you given Maxelf and sent her? Now I am not able to extubate her. She is not having spontaneous respiration. He is very mad at you. Can you explain it to him that it was necessary to give Maxelf with evidence-based discussion? You tell me first, should we continue Maxelf when patient is being sent for cesarean, or should we stop that dose?
Ma'am, we give the Maxelf because
Why?
it is, ma'am,
What is the half-life of Maxelf? Maxelf, if you stop, half-life of Maxelf is 5 hours. Okay. So even if you stop, it is going to be there in the circulation at the time of cesarean.
Okay, ma'am.
So it is not going to help the anesthetist in any way for extubation or recovery time. The only thing is it will worsen the condition of the patient, and patient will be more prone to have convulsions. So if someone tells you, then you should have this explanation ready that before giving cesarean, because half-life is 5 hours, we have to continue during delivery or cesarean this Maxelf. We don't have to stop the dose.
Okay.
And for how long should it be continued after delivery?
Ma'am, 24 hours of the last season, yeah, 24 hours after the delivery.
Okay. Suppose you have done cesarean of this patient and you have shifted the patient to the post-op. She was fine, and from there she has been shifted to the ward. Do you need to take any special precautions of this patient in the post-operative period?
Yes, ma'am.
What are they?
Maxelf is to be continued, ma'am.
Yes, one is Maxelf to be continued. Okay, second.
Deep tendon reflexes, we should check the RR,
Respiratory
rate,
and urine input-output charting.
Okay. What else?
And blood pressure monitoring. And
yes, PP monitoring. Yes, PP monitoring is very essential. For how long?
Ma'am, till the BP is normalized and.
बेटा उसका नॉर्मल तो शायद हफ्ते तक नहीं होगा.
Ma'am, then
are there? Okay, let me ask in another way. Will the BP in this patient increase after delivery, or it will stabilize?
Ma'am, it will stabilize.
Initially?
Initially, it may be increased.
It may be increased because?
Ma'am, because of the placental inflammatory mediators release. That's why.
Because the?
Placenta तो निकल गया.
Placenta तो निकल गया.
Ma'am, increase in the cardiac output.
Cardiac output increase. Initially, it might increase, but then it will stabilize. Okay. Which antihypertensives are safe in postpartum period for a lactating mother?
Amlodipine.
Okay.
Then labetalol can be given, ma'am.
Okay.
Diuretic should be avoided.
Okay. What else can be given? Patient is a poor one. She doesn't want the costly medication.
Amlodipine.
Can ACE inhibitors be given?
Yes, ma'am. ACE inhibitor given, not ARB.
ACE inhibitors can be given. Okay. Okay. What is the side effect of amlodipine? You are speaking that amlodipine can be given. What is the side effect of amlodipine?
Ma'am, fetal edema. Ma'am, fetal edema, tachycardia.
Tachycardia, fetal edema. What else? The headache which occurs because of this calcium channel blocker is very distressing for some patient. And you had operated this patient for headache and with high BP. You remember? This patient was already, so this headache might disturb her. Okay, which are the drugs, antihypertensive drugs, which are contraindicated in lactation?
Ma'am, in pregnancy.
No, pregnancy, I know you know, ARBs and ACE. In lactation.
In lactation. Ma'am, ARB.
Is ARB why is ARB contraindicated in lactation?
Ma'am.
Dr. Manisha, are they contraindicated in lactation?
I don't know.
ARBs are.
I think it can be given.
They can be given. Okay. Postpartum patients in pregnancy, they are contraindicated. Yeah, someone was writing methyl dopa. Someone is in the chat box, methyl dopa. Yes, methyl dopa is contraindicated. But Smriti, can you tell me why is it contraindicated?
Ma'am, it causes the postpartum depression and rebound hypertension.
Postural hypertension, postpartum depression. Yeah. Okay. Patient of preeclampsia with severe features, eclampsia patient. Okay, you have operated this patient. For how long would you like to keep her in the hospital? When will you discharge her?
Once your BP gets controlled, ma'am.
When BP gets controlled.
Yes,
which is the postpartum period when they are at maximum at risk?
48 hours postpartum.
Ideally, patient with eclampsia should not leave the hospital before 7 days. Patient with preeclampsia who has received Maxal for severe features should not leave hospital for at least 5 days. They should be monitored. At 7 days, they are maximum at risk of thromboembolism. How will you prevent the thromboembolism in such patients?
By giving them TVT prophylaxis, we can start with a low molecular weight heparin and graduated stockings. Early ambulation.
So early ambulation, you should be speaking first of all. Now, when you say low molecular weight heparin, then your viva will move towards towards the anticoagulation during this. Now tell me, what is Dr. Manisha? Sorry, you can continue. Okay, tell me. I think we're short of time. Let's ask about let's wind up contraception. Should we ask?
Yes, contraception.
Yeah. Which contraception would you prefer in cases of hypertensive disorders of pregnancy patients?
Barrier contraception.
What is the failure rate of barrier? जब एग्जामिनर आपसे कॉन्ट्रासेप्शन पूछता है ना, वो बैरियर बिल्कुल नहीं सुनना चाहता. बैरियर्स हैव वेरी हाई फेलियर रेट. आपने बैरियर बोलना है तो लास्ट में बोलोगे. ठीक है, तो कौन सा कॉन्ट्रासेप्टिव सेफ है हाइपरटेंशन में? स्मृति,
can we give mini pill, PP, IUCD?
They are writing in chat. Priti is writing in chat box. She has written all those PP, IUCD and.
What about DMPA? Can we give DMPA, Smriti?
Yes, ma'am. DMPA can be given.
Can be given?
No, ma'am.
No, it is relative contraindication because it is considered not to be given in patient with hypertension. So apart from that, you can give mini pill, you can give PPIUCD. So these things can be given.
Chaya can be given, implants can be given.
Implants can be given, right. What about next pregnancy? This patient had preeclampsia in this pregnancy. What would be, how would you guide her in the next pregnancy?
will ask preconception counseling. Will do the preconceptual counseling. Will ask her to take folic acid 3 months before she planning the pregnancy. Will counsel her that she's at the high risk of developing preeclampsia in in the future pregnancies also.
So after delivery, after 3 months, you are certainly going to call her and see her what is her BP like. Maybe she might be a chronic hypertensive also. So you would like to see her blood pressure before, after 3 months and before conception also. You're right, pre-conception counseling is very important. But in the next pregnancy, when she comes to us, she had already had a preeclampsia earlier. So she has a major risk factor. But still, if you have facility, you will do a screening test for her. And we didn't at that time we didn't mention about the uterine artery. So you can always do uterine artery PI, and you can do certain markers like PLGF, you can say, to screen that patient in that pregnancy and to understand whether this patient is at high risk or not in this pregnancy, and start her on Ecosprin. Is there some other drug also that we can give, we should give, and we can give to prevent preeclampsia?
Calcium.
Apart from Ecosprin? Aspirin?
Given, ma'am.
Yeah.
Calcium.
Calcium, yes. So calcium is adequate dose. So there should be not, the deficiency of calcium should not be there. Okay. Anything else? Some other drug which has come, which is still in research?
Statins.
That is a experimental drug still in the trials only.
DEGF.
Statins are there. Pravastatin is there, which is still under research. So that is there. And apart from that, always in the exam also and in practice also, ask the patient, talk about the exercise, sleep, all these things, and food habits. All these things are also very important in prevention of preeclampsia. We talk only about Ecosprin and we don't talk about those things. I think the time is over.
Yeah. Okay.
Very nice.
Thank you. Very nicely presented.
Very nicely answered also.
It's pretty well done. Preeti, you are also very good. Thank you, Dr. Manisha.
Thank you, Dr. Poonam. It was a pleasure.
Yeah, same here.
Thank you, ma'am. Thank you for conducting this session of hypertensive disease in pregnancy with greater elaborations. Now I want to move to another segment. The next topic is AUB. And to moderate the next session, I want to invite Dr. Manju Puri. She is Director Professor, Department of Obstetrics and Gynaecology, Lady Hardinge Medical College. And
Please unmute yourself. Dr. Nepune, please unmute yourself.
Ma'am, I also want to introduce Dr. Sunita Kumar. She is a senior consultant, obstetrician, gynecologist, and laparoscopic surgeon. To present the case, we have Dr. Payal. She's a primary DNB trainee, and Dr. Ritusri. She's also a primary DNB trainee, ma'am. Over to Dr. Payal and Dr. Ritusri. Please present your case.
Dr. Payal, Dr. Ritushi, are you logged in? Should be.
Dr. Preeti, who is starting? We can't hear you.
Ma'am, we are trying to share the PPT.
Okay.
Ma'am, we're facing some technical problems. So sorry for the delay, ma'am. Good afternoon, ma'am. The topic of
Just be a little loud. We can't hear you. At least I can't hear you.
okay, good afternoon. The topic of our presentation is abnormal.
It's not very audible.
No, you have to be louder.
You have to be louder.
By Dr. Payal Huda, first year DNB trainee, and Dr. Shri Patnaik, first year DNB trainee. From the
Beta, you have to be loud. Please understand. We can't hear you, so we can't actually understand what you are saying. So you have to fix up your voice.
Okay, ma'am. Ma'am, we are audible now?
Yes, but faintly. You are audible, but very clear.
It is not satisfactory. It is not satisfactory.
Okay, ma'am. The topic of our presentation is abnormal uterine bleeding. Now, the presentation is the chief complaints are our patient Mrs. X, 44 years old, homemaker, multi-paris female, wife of Mr. Y, resident of Lakshmi Nagar, New Delhi, presented with complaints of heavy bleeding per vaginum with passage of clots and pain during menses since last 2 years. She has a history of heavy bleeding PV with passage of clots since last 2 years. Patient was changing 5 to 6 fully soaked pads per day on first 3 to 4 days, followed by 2 to 3 pads per day. This affected her daily routine and household work. She also have a history of pain during menses, which was dull aching, non-radiating, and localized to lower abdomen and lower back, with a pain score of 6 out of 10. She was, which was relieved on taking medications. Patient was asymptomatic till 2020, had regular menstrual cycles. She started complaining of heavy menstrual bleeding with passage of clots and painful menses. She had consulted a local gynecologist and was advised hormonal treatment, TAB Primolute N, for 3 months. But the symptoms persisted. Hence, she was advised hysteroscopy DNC and Mirena insertion, which she has undergone. She had irregular bleeding per vaginum on and off till 2.5 years back when she expelled Mirena spontaneously 3 months ago, following which she again complained of heavy menstrual bleeding with clots and pain abdomen. On asking, she had a histopathology report of previous procedure, which was suggestive of endometrial hyperplasia without atypia. There is history of NSAIDs for relief, history of hormonal treatment, Primolute N, and history of IUCD 2 years back. No complaint of intermenstrual bleeding, postcoital bleeding, dyspareunia, no complaints of bowel and bladder complaints, no history of trauma, no history of infertility, prolonged bleeding from wounds, bleeding from other orifices, no history of loss of appetite, weight loss, no history of heat or cold intolerance, irritability, loss of weight, no history of abnormal vaginal discharge, lethargy, cold intolerance, and fatigue. No history of taking of any anticoagulants or any other medications. Her menstrual history is menarche at the age of 13 years. Her last menstrual periods were on 22nd April 2023. Her present menstrual cycles are, duration is 10 days and the cycle length is 28 days, regular, heavy flow with dysmenorrhea associated with clots. Patient gives history of changing 5 to 6 pads completely soaked per day on first 3 to 4 days, followed by 2 to 3 pads per day. She had undergone hysteroscopy DNC with Mirena insertion in 2020. Had irregular bleeding per vaginum on and off since then, but there was no complaint of pain during the menses. Mirena was expelled spontaneously 3 months back in January. Her past menstrual cycles before 2 years were duration of the periods were 4 to 5 days with a frequency of 28 days, regular, and average cycles were painless. Her OBS history is Para 3, Life 3. She's married for 21 years. All were full-term normal vaginal deliveries. Last childbirth was 14 years ago. Eldest child is 19 years old.
Her antepartum and postpartum course were uneventful in every pregnancy. There is no history of PPH or blood transfusion. Contraceptive history. History of tubectomy 14 years back. Past history. History of hysteroscopy DNC and Mirena insertion in 2020. There is no history of diabetes mellitus, hypertension, bleeding disorders, tuberculosis, malignancy, or any other medical condition. Her family history. Her mother is hypertensive and she has type 2 diabetes mellitus. There is no history of malignancy in the family. Her personal history. Social economic history. She belongs to upper middle class as per the modified Kupuswamy scale. Her dietary intake. She is vegetarian and adequate calorie intake. Her sleep and appetite are normal, no addictions, and bowel and bladder habits are regular. On general physical examination, the patient is fair, average build, gait is normal, patient is conscious, oriented, cooperative, well oriented to time, place, and person. Height was 155 centimeters, weight 65 kgs, BMI is 27.1 kg per square meter. Afebrile to touch, no pallor, cyanosis, clubbing, edema, icterus, lymphadenopathy. Pulse rate was 72 beats per minute, good volume, rhythm and character, no radioradial or radiofemoral delay. Blood pressure was 120 by 80 mmHg taken in sitting position in the left arm. Respiratory rate 18 per minute, good oral and dental hygiene. On thyroid examination, it was normal. Breast examination was normal. Systemic examination, cardiovascular system, S1, S2 was normal, no murmurs. On respiratory examination, bilateral air entry was equal on both the sides. Vesicular breath sounds were heard, no adventitious sounds. On per abdomen inspection, umbilicus was central and inverted. Contour of the upper abdomen was normal, moving well. All the four quadrants were moving well with respiration. Palpation, the abdomen was soft and non-tender, no hepatosplenomegaly. Hernial orifices were free. On percussion, no free fluid was felt in abdomen. On percussion, normal bowel sounds were heard. Local examination, external genitalia appeared normal. On per speculum examination, cervix and vagina were found to be healthy. Per vaginum examination, cervix was downwards and backwards. Uterus was anteverted, enlarged to 8 to 10 weeks, which was globular, firm, non-tender, mobile. Bilateral fornices were. So in short, the clinical summary is the 44-year-old female, para 3, life 3, presented with complaints of heavy menstrual bleeding with passage of clots and dysmenorrhea since 3 months after Mirena expulsion. On examination, she was average build. Per abdomen was soft, no tenderness was felt. On per speculum examination, cervix and vagina was found to be healthy. On per vaginum examination, uterus was enlarged to 8 to 10 week size, non-tender, firm, globular, mobile, and bilateral fornices were free. This history is most probably suggestive of AUB, endometrial hyperplasia. The provisional diagnosis is a 44-year-old para 3, life 3 with abnormal uterine bleeding endometrial hyperplasia. Differential diagnoses are adenomyosis and leiomyoma.
Okay, so why have you made the diagnosis as endometrial hyperplasia?
Ma'am, because the histopathology report 2 years ago, which was done during hysteroscopy DNC, was suggestive of endometrial hyperplasia. And she also complained of heavy menstrual bleeding even after expulsion of, even after hysteroscopy DNC and Mirena, which was failed to control with the hormonal IUDs.
So what do you expect the Mirena to do? It was there inside the uterine cavity for 2 years, no?
Yes, ma'am.
So do you think that endometrial hyperplasia must have persisted?
No, ma'am. Mirena causes atrophy of the endometrium, but in this case, the patient did not get any relief after even Mirena insertion.
So other than the previous history of histopathology, I'm to say when she's come to you now, So I think making a histopathological diagnosis of endometrial hyperplasia here may not be correct, right? And is it common for patients who have endometrial hyperplasia to have pain? Dysmenorrhea?
No, ma'am.
Right? So I think that is fine that she had that finding of endometrial hyperplasia at that particular point in time. Either you say she is an old known case of endometrial hyperplasia, but from what do you think is she more likely to be?
Ma'am, adenomyosis.
Yeah. So that, clinical diagnosis would be more of adenomyosis with previous history of endometrial hyperplasia. That is how you can put it. It may be kind of explaining most of the things, right?
Yes, ma'am.
Okay. One more thing which I want to know is that when you talk about the history and about the symptom, you did not tell us what was the onset like. So a woman who's been having regular periods, you said 2 years back, is it that she suddenly started having problems, or was the problem,
it was insidious in onset.
Yeah. So I think whenever you have a patient of abnormal uterine bleeding, so the onset and the progression, both should be talked about.
Okay, ma'am.
Right? And what was the spatial, presentation? Which came first? Was it pain or was it abnormal uterine bleeding?
Abnormal uterine bleeding.
So she initially had heavy menstrual periods.
Yes, ma'am.
How many months after that did the pain come?
Ma'am, after 3 to 4 months, she started having dysmenorrhea.
Yes. So all that information which you have with you should be shared when you are presenting the history, right? Otherwise, I think any risk factors this patient has got? Risk factors for malignancy?
Ma'am, no, ma'am, she did not have any risk factors.
What is the BMI?
Ma'am, her BMI was 7.1 kgs per square meter, which is normal, ma'am.
27 is normal?
And slightly towards obesity. Risk factor is considered if the BMI is more than 35.
No. That is fine, but she definitely is high BMI, right? It may not be an out and out risk factor, but then she's not normal BMI. That is what you must know. And if we go by the Asian standard, then definitely this BMI is not correct. 25 and more would be obesity. If I go by Asian standards. Is it right?
Yes.
Right. So that is the only factor which we can see now. And her blood pressure is normal, you said?
Yes, ma'am.
So no history of diabetes in this patient?
No, ma'am.
All right. So Dr. Sunita, over to you in case you want to know anything in history or examination. I thought we can finish that.
I think they've covered everything. The family history, if you're sure about the family history, no family history of any genital cancers or anything?
No, ma'am. No, ma'am.
Right. Then she stands into low risk, and no history of PCOS or anything in the previous menstrual history or anything.
Her menstrual cycles were fairly regular. There was no history of PCOS.
And 3 deliveries, no other problem.
No.
So nothing getting towards PCOS.
Yes, no.
No.
Not have any.
Right.
So she stays as low risk, right? So now we go ahead and manage this patient. Now this patient has come to you in the OPD. So what are you going to do with her?
And first, we will investigate further. We will send all the blood investigations like CBC, her coagulation profile, thyroid profile, liver profile, kidney profile, chest X-ray in case she we decide a surgical intervention.
No, but just hold on. I'm to say the first part is that we have to focus on the diagnosis part, no? And you can't order all the investigations in one go. So tell me the relevant investigations which you're going to do in this patient.
Ma'am, initially
first line investigations.
Ma'am, first we'll rule out the pregnancy. We'll perform the urinary pregnancy test, as it is compulsory to perform in every heavy menstrual bleeding. If the patient presents with heavy menstrual bleeding, then we have to rule out the pregnancy.
Well, she had her periods on 22nd 4, right? So your pregnancy test may not give you any clue here.
Yes, ma'am.
right? Today is 23rd, right?
Yes, ma'am. Yes, ma'am.
That's fine. Okay, but it is important to do it, but in this patient, it may not be that important. It's fine. Okay. Go ahead. What else are you going to do?
Ma'am, we'll send the complete blood count, bleeding
Excellent.
and profile,
Yes.
and her thyroid function test, and we'll also collect the pap smear.
Yes.
And serum prolactin also we will send.
Serum prolactin, and you also want to do a pap smear. Okay. All right. So that's relevant. And you have not taken the history of pap smear. In your history, you must find out whether the patient has had a pap smear done in the past. Did you find out?
Yes, ma'am, it was done before hysteroscopy and dilatation and curettage procedure.
So that was done how many years back? 2 years.
2.5 years back.
Okay. So we'll take a pap smear. It is absolutely fine, right? What else are you going to do for this patient?
After that, if all these reports comes normal, then we'll send the patient for ultrasound, transvaginal ultrasound.
No, but why do you want to wait for these reports and then send the patient for ultrasound?
No, ma'am, we'll send her immediately.
Ultrasound will be a part of your initial workup, no?
Yes.
Right? So you want to get an ultrasound. So what do you want to see on ultrasound?
Ma'am, the palm classification constitutes the structural abnormality.
No. I am asking you on ultrasound, what are you going to? I am not asking you about palm coin. Please listen to the question carefully and give me an answer to that. So on ultrasound, what prescription right for the ultrasonologist to look at? You can't ultrasound. Sorry, go ahead.
Endometrial thickness, ma'am. Ma'am, first of all, we will see.
What will you write for this thing?
No.
I mean, what all do you want to see on ultrasound?
Yeah.
Ma'am, first of all, we will see the size of the uterus, anteverted or retroverted, and then we will look for any the shape of the uterus, whether it is globular or irregularly enlarged, or any focal lesion is present or not. We will see the endometrial thickness, both the bilateral adnexa and both ovaries.
There is some disturbance. Please put someone mute.
Sorry, ma'am.
What is the background noise? And you be a little loud. Yeah.
We will see both the ovaries and the size of the ovary. We will see the bilateral adnexa are free or not. We also see the if there is any collection in the pouch of Gurukul.
And so she's a perimenopausal patient. You've said you're going to look at whether it is retroverted or anteverted. Do we use ultrasound for that?
No, ma'am. We can.
You said you want to see whether it's globular.
By manual examination. Also.
Yeah. So we asked you a question wherein we asked you what are the features which you're going to ask for, things which you ask for on ultrasound. So you should be very, very, articulate when you tell us about that. What is this background noise? Can that Dr. Sunita, are you hearing it as well?
Yeah, no, there is disturbance, but I've asked them to.
Could you please ask someone to?
Yeah, I just checked.
So, beta, when you are asked, you should be very clear as to what you're going to ask for the size of the uterus, right? You're going to ask for the texture of the myometrium. You want to know the thickness of the endometrium. You want to know the endomyometrial junction. Isn't it? So these are the things which you're going to look at. And then you want to look at the adnexa. Right? So these are what are relevant as far as your abnormal uterine bleeding is concerned, isn't it?
Yes, ma'am.
Okay. So I said endomyometrial junction. Why do you want to have a look at that?
Ma'am, in case of adenomyosis, endomyometrial junction is the thickness is increased. More than 12 it is usually more than 12 mm.
I am not able to hear, and
there is this
we can't continue with the session like this. Can we have who's the administrator here?
Just let me see.
Ma'am, it is what we are also hearing.
But who's the administrator? It looks like there is a presentation going on the background, no? Dr. Sunita, मेरे को ही सुन रहा है या आपको ही सुन रहा है?
No, नहीं हमें भी सुनाई दे रहा है. I mean, there is disturbance, but I don't know how it's there. We have some cross connection. Just let me check on it.
There is some parallel session going on.
Are we audible?
नहीं बेटा, there is a parallel session going on और आपकी आवाज हमें नहीं आ रही. We can't go on like this because ऐसे नहीं समझ आ रहा है. बेटा प्लेटफॉर्म कौन मैनेज कर रहा है? Do we have someone from the group who is managing the platform? Yeah, it is quite now. That is fine. चलिए अब आप बताइए बेटा. हाँ.
On ultrasound, we want to
ठीक हो
see
गया,
the
हाँ जी.
endomyometrial junction because if we are suspecting a case of adenomyosis, then the endomyometrial junction might be irregular or there is loss of differentiation between the endomyometrial junction. We might see basically there is loss of endomyometrial junction.
No, but what other thing comes to your mind in case there is loss of
We can see heterogeneous eco texture on in the
Beta, please
myometric.
listen to the question carefully. I asked you what is the other differential diagnosis which comes to your mind if endomyometrial junction is disturbed.
Ma'am, fibroids.
Sorry?
Fibroids, ma'am, leiomyoma.
In leiomyoma, the endomyometrial junction will be distorted?
Ma'am, in case of intramural and malignancy, ma'am, it could be malignancy also.
You can't look at the chat box and give an answer. You must know the answer yourself. So there are only two differential diagnoses. which
Endometrial malignancy, we might
Yes.
See the loss of endomyometrial junction.
Right. And what are the other features of adenomyosis on ultrasound?
Ma'am, there may be heterogeneous ecotexture which might be seen on in the myometrium. There might be asymmetrical myometrial thickening on one side. There may be myometrial cysts. Fan-shaped shadowing might be present from the endometrium to the myometrium. There might be subendometrial bands and striations. Ma'am, if we see on Doppler ultrasound, then we might see increased vascularity around the lesion.
Fine. I think you've listed out most of them. So you're going to do an ultrasound. So you do an ultrasound, you do a CBC, TSH, prolactin, and a pap smear. Okay?
Yes,
all right. Fine. And you've had a look at endometrial thickness as well.
Yes, ma'am.
All right. So over to you, Dr. Sunita. You have to unmute yourself, Dr. Sunita.
So, okay, with this ultrasound report, what is your diagnosis now?
Ma'am, para-3 live 3, 44-year-old female, multiparous, para-3 live with abnormal uterine bleeding, adenomyosis.
Adenomyosis. So can you think of any reason why the Mirena got expelled?
Ma'am, most probably because the size of the uterus is enlarged, the shape of the uterus is distorted.
Why do you say the shape is distorted?
Ma'am, the size of the uterus is enlarged, 8 to 10 week size.
You think that is the reason why Marina was expelled?
No.
Could it be improper insertion only right from the beginning? Faulty insertion?
Yes, speak. Come on, answer. What could you, what could be the reasons for the expulsion?
Are you girls there?
Oh. Okay, one man has already told you it was a fault. It could have been a faulty insertion. She is multiparous, patula sauce. Maybe the dilatation or everything, whatever was done was not proper.
Or maybe there was a fibroid which had become submucous.
I was just coming to that. When you say cavity, There was a fibroid, but can you put a Mirena for in cases of fibroid also? Can you or can you not? There's nobody over there.
Payal, are you there? Hello, are you there?
Ritushri, Payal.
Are you muted? Please unmute yourself. Where have the girls gone?
Ritushri? I think they can't hear us. We can hear. We can only hear the.
Ma'am, are we audible?
Yeah, now you people are audible.
Yes.
Come on,
Sorry,
answer.
So we were asking the
There's a lot of-
reasons. Yeah, reasons why the Mirena got expelled.
Ma'am, the size of uterus is enlarged up to 10 to 12 weeks, and because of the enlargement, the Mirena got expelled, and in adenomyosis, the uterus is uniformly enlarged.
That is no reason for expulsion.
And ma'am, due to heavy menstrual bleeding,
But
it got expelled.
you don't expect heavy menstrual bleeding, no? With Mirena inside, there wasn't so much of a heavy menstrual bleeding. You were already given a hint that it was not a insertion. First thing is that probably people missed out something in the cavity. That could also be one of the reasons.
Yes, ma'am.
Then sometimes, myometrial contraction, especially adenomyosis and all, can lead to expulsion. What's Dr. Manju?
Yeah, that's fine. It can. Yeah. So anyway, once it's got expelled, so that is why a reevaluation is important at this particular point in time.
Yes, ma'am.
And the management will be based on whatever is the reevaluation now. And did you ask her, was she happy with Mirena? Was she not happy with Mirena?
Ma'am, she was comfortable with Mirena. Her symptoms resolved after when she was using Mirena.
Right.
But her symptoms reappeared after the expulsion of Mirena.
All right. Would she be keen on taking Mirena once again? Did you talk to her?
Yes, ma'am, but she was not keen for the Mirena, and she wanted definitive treatment.
All right. Why was she not keen for Mirena?
Ma'am, because she already had a history of Mirena expulsion, so she did not want to try Mirena again.
All right, fine. So what are you going to do now?
Ma'am, in this case, the patient wanted definitive treatment, that is hysterectomy. So we counseled the patient about the various routes of hysterectomy, that is abdominal.
No, just hold. She said that she probably might have thought this is the only method which is okay now, but did you offer her other methods and did you counsel her for other methods? She's already 44 years of age.
Ma'am, she already had a history of NSAIDs intake and oral progestogens. She already had undergone hysteroscopy DNC, so she did not want any other methods to try, ma'am. So she wanted definitive treatment.
No, what other methods can you offer?
Ma'am, we can put her on oral progestogens again. We can offer her endometrial.
No, hold on. Oral progestogens, how? In what dosage, in what schedule?
Ma'am, medroxyprogesterone acetate can be given, norethistone can be given, norethistone 5 to 10 mg, TDS can be given from the day 5 of cycle till day 22 for 3 cycles it can be given.
All right, fine. Why only 3 cycles? You can't give it for longer?
Ma'am, we can give it for longer.
Right.
We'll reassess the patient after 3 months and then we'll continue for another 3 months.
Yeah, if you diagnose adenomyosis, then she might have to be given for longer intervals, right? So you might give her for 9 months, 1 year as well, right?
Yes, ma'am.
So you have to give her for a long term. What are the side effects with oral progestogens?
Ma'am, there are mood changes. She might develop GI upset, GI problems, bloating, headache, and she might complain of weight gain, ma'am.
No, more
if she
serious.
stops, if she doesn't take medication properly, she might also develop irregular menstrual bleeding.
No, what investigation should you be monitoring when you put a patient?
Ma'am, LFT, liver function tests, and lipid profile.
Liver function tests don't get deranged by estrogens. So it is lipids do get deranged. Which other investigation gets deranged? What are the metabolic side effects of progestrogens? The sugars also get deranged. So you have to monitor the blood sugar. You have to monitor the lipids. So these are the two investigations which you must monitor, right? Because it can really make them haywire. And of course, you must monitor her blood pressure as well. So these are androgenic side effects of the progestrogens which you give. So this is one you can. What else can you offer?
We can offer her combined oral contraceptive pills.
Right. Yes, you can definitely offer a low dose.
Yes, ma'am, low dose. Mala N can be offered.
Excellent. All right. What else can you offer?
Ma'am, GnRH analogs can be given to the patient, can be offered to the patient.
What dose and how would you like to do that?
Ma'am, leuprolide can be offered 3.75 mg intramuscularly monthly or 11.25 mg 3 monthly.
Right.
And gostrelin 3.65 mg subcutaneously can be offered.
All right.
Along with the GnRH analogs. Any other advice?
Ma'am, couldn't hear you properly. Sorry, ma'am. Can you repeat the question once again?
Will you want to give any other advice with GnRH analogs?
Ma'am, she might get, we will counsel the patient that she might get menopausal symptoms like hot flashes.
And?
Ma'am, we'll add Advec therapy after few months.
No.
After how many few months? How soon will you see? What are the changes in the body if you give GnRH analogs? What are you?
She might complain of dryness in vagina. She might complain of hot flashes. Perimenopausal symptoms might appear soon. She might complain of bone pain, decreased bone mass, osteoporosis. That's if we continue if we advise GnRH for more than 6 months, then we have to give her add-back therapy, ma'am. So low dose estrogens have to be added in that case.
And your patient
3 to 6 months only 5 to 8% decrease in the spine BMD.
Ma'am? Sorry, could not hear you.
I said within 3 to 6 months of your treatment with GnRH analog, the patient might show you a decrease of 5 to 8% of spine BMD. So
yes, ma'am.
Once you give her start on GnRH analog, I think after 3 weeks you should put her on
calcium and vitamin D supplement.
Definitely, yeah. And
can I just come in, Dr. Smita?
Yeah, please.
This patient is 44 years of age. So
yes, ma'am.
Who comes to you in the perimenopausal age group? I think you must start her on calcium and vitamin D irrespective of yeah. So in this patient, you are definitely going to start her on calcium and vitamin D. You will going to assess her vitamin D also and give her calcium and vitamin D at the very beginning, right?
Right, ma'am.
So over to you, Dr. Smita, please carry on.
Right. Okay, now you want to give her a definitive treatment. What if she said, I do not want to hysterectomy? What else can you offer?
Ma'am, we can offer her endometrial resection or endometrial ablation techniques.
Right. And what are they? Just to
they are two.
Ma'am, first generation and second generation, there are two types. In first generation, there is the transcervical resection of endometrium is there, and laser ablation is there, and laser ablation and radio frequency ablation is there.
Right. Okay. What in the second generation?
Ma'am, microwave endometrial ablation is there, thermal ablation, thermal balloon is there, and radio frequency also.
Yeah, but this patient already had hyperplasia. So what are you scared if you're giving her endometrial ablation?
Ma'am, it might be.
Yeah, it is seen that after endometrial ablation, many of them do develop CA changes, and it's difficult to pick up.
It might progress too soon.
Yeah.
Yes.
I have a question for you girls. Tell me that before you offer her any kind of therapy, would you want to do a repeat assessment of the patient as far as her endometrial biopsy is concerned, or a hysteroscopy? Would you like to do anything of these again?
Ma'am, after 3 months.
No.
Ma'am,
She's come to you now after she's expelled Marina. So you have missed out something in the history which we should have found out in the history itself. Did she have a repeat DNC or sampling done anytime after she was treated?
No, ma'am, there was no history of any endometrial sampling after she had undergone DNC.
So is it actually recommended in patients who have hyperplasia when we treat them? Are we supposed to?
Ma'am, ideally they should undergo the repeat testing after 6 months of starting the therapy. If her symptoms have resolved, then she should again undergo the sampling after 6 months. In case of Mirena, if the symptoms are resolved, then she can continue it for the next 5 years.
So because she had Marina inside, so probably that is why a repeat sampling was not done, right?
Yes, ma'am.
Would you like to do it now?
Ma'am, it can be,
Yes, ma'am.
it can be done, ma'am. In case of
Just go ahead with the sampling, or you would like to first see something before you advise endometrial sampling?
Ma'am, first of all,
ultrasound.
we'll see the endometrial thickness on ultrasound. On the basis, if we suspect any endometrial thickness, then we will go for endometrial sampling in this case.
Okay, and how will you decide the thickness of the endometrial?
Go ahead.
Ma'am, for postmenopausal, it is more than.
She's not postmenopausal. She's.
Ma'am, ma'am, in this case, more than 12 mm. If the endometrial.
But at what time of the cycle? Just before her periods?
No, ma'am. No, ma'am.
Ma'am, in proliferative phase.
In proliferative phase.
Post-menstrual, if she's she's having 12 mm of endometrium, definitely you'll have to do a sampling.
Yes,
no, just a second. In post-menstrual period, what do you expect her endometrium to be in case the hyperplasia is resolved? What is normal in the post-menstrual period in a perimenopausal woman?
So the endometrium is anywhere between 5 to 10 mm, ma'am.
5 to 10? If the post-menstrual is more than 5 mm, is it normal?
No, ma'am. It is
normal.
It is till 2 mm.
No.
5 mm is normal.
5 mm is we take as the upper limit is normal. No, so it doesn't have to be 12 mm for you to take a biopsy. Right. So if it is more than 5 mm, we would be uncomfortable about. Okay, right? Post-menstrual should be
4 mm.
5 mm. 4 mm, yeah, less than 5 mm. That is what we are, comfortable with. That is what you must remember. And when you're talking about 12 mm, 15 mm, all this is premenstrual endometrial thickness.
Yes, ma'am.
Right? If it is more than 12 mm premenstrually, we would consider it abnormal. Some people consider that as 15 mm. 12
yes,
mm is also given as one of the cutoffs in a perimenopausal woman. Okay?
Yes, ma'am.
Over to you, Dr. Sunita.
Now you've done a again repeat sampling also, and that again says hyperplasia. Now what you want?
Ma'am, we will come
the patient for any other treatment, or she just wants a definitive treatment and you are going to go ahead with hysterectomy?
Ma'am, we will counsel the patient about all the available treatments in this case, all the possible treatments in this case.
Anything else? Okay, you've searched ablation. Anything else?
Definitive treatment.
Definitely.
Will you go with a definitive treatment, or if she has still persistent hyperplasia, would you like to go with definitive treatment or no?
Yes, ma'am. If she has persistent hyperplasia, we will go for definitive treatment.
Yes, she's had Marina for 2 years and 3 years, and now she's again got hyperplasia, so you will go with her decision of definitive treatment.
Definitive treatment, yes, ma'am.
So what next? So what are you going to counsel her about now?
Ma'am, first of all, we'll counsel her about the various routes of surgery which she can opt for. That is laparoscopic route or abdominal route or vaginal route. Ma'am, in this case, the patient's uterus is around 8 to 10 weeks. So she opted for laparoscopic route of hysterectomy.
No. I'm saying you are not going to, you are going to tell us the advantages and disadvantages of each.
Ma'am, we will counsel the patient about each route of surgery. That is, in abdominal hysterectomy, the scar would be of greater size. It needs less expertise. All surgeons can perform it. It can be easily performed in uterus.
Are you going to tell the patient it needs less expertise and all the surgeons can perform it? What are you? The patient, what are you going to tell her about the history?
Yeah, this is not the way you are going to counsel the patient, no?
Yes.
The advantages and disadvantages of the method.
Of any hysterectomy pehle batao, and then about laparoscopic and the open one. Any hysterectomy, what are you going to tell the patient? What should she expect for the future?
Ma'am, her menstruation will stop, and childbearing function will stop. She cannot.
Okay.
Ma'am, about ovaries also we will counsel, as she's 45 years old. So we will counsel her about the oophorectomy or pros and cons of oophorectomy.
Just a second. In a patient who is menstruating and who is not menopausal, do you offer removal of the ovaries to these patients?
No, ma'am.
So why are you saying she's 45? That means somewhere the cutoff in your mind is not correct. This is a very old cutoff.
Okay.
Right? So we don't offer oophorectomy. We would counsel them. We'll tell them the advantages and disadvantages. I'm saying at 44, if she is menstruating, I will definitely, I'm saying it is always better not to remove the ovaries in these patients, right?
Yes, ma'am.
Right. So you have to be very clear. So what advantages and disadvantages would you explain when we talk about the oophorectomy part?
Ma'am, there is risk of about 2% of ovarian cancer if the ovaries if oophorectomy is not done. We will counsel the patient.
Hold on. Why do you say 2%? Where does this figure come from? Will she have the risk of ovarian cancer more as compared to the other women or less as compared to the other women?
Ma'am, more as compared to the other women.
Why?
Because her endometrial thickness is increased and she had endometrial hyperplasia. So she's persistent and she was refractory to medical treatment.
So how will that affect the ovarian cancer? Genesis of ovarian carcinoma? Is it a high risk factor for ovarian carcinoma?
No, ma'am.
So the incidence, it will be lesser because you have seen the ovaries. So you have, visualized the ovaries. If they are looking normal, they have relatively lesser chances as compared to the normal population. This is how we have to explain it to the patient, right?
And she's being put on so many hormonal contraceptives and everything. So lesser number of ovulation, a little lesser chances for ovarian cancer.
Okay.
Lesser
as compared to the normal population.
Yeah.
What you're going to explain, right? Okay.
Right, ma'am.
Okay. What else are you going to explain? What other advantage she has of retaining the ovaries? What is the advantage of retaining the ovaries?
Ma'am, she will not have postmenopausal symptoms like hot flushes and night sweat and osteoporosis.
And
ma'am, genitourinary symptoms, dryness of vagina.
It is जो long term ovaries उसका long term जो implications है, that is what we talk about. We talk about cardiovascular benefits. We talk about bone health. Very important.
That's so important.
Okay, but what are the advantages of removing it? One is that the risk of malignancy would reduce. Any other advantage of removing?
Ma'am, cyst formation can also be there if ovaries are left behind. So Which can further develop into.
Yeah, so subsequently have to have, rarely she might have to have a surgery for that. Okay, and what else? Does the removal of ovary have any impact on breast malignancy?
Yes, ma'am, it is protective.
Yes, so these are the advantages, but given her age, I'm to say you have to counsel her more in favor of retention in case the ovaries are absolutely normal looking and there is no family history of ovarian malignancy and there's no genetic predisposition for ovarian malignancy, right? So this is how your counseling should go in.
You'll leave the ovary, but what about the tubes? You'll remove the
And
tubes
we'll
or
take
no?
out the tubes also.
We'll do bilateral sulfingectomy, ma'am.
Why? How does it affect?
Ma'am, it will reduce the risk of
how
ovarian cancer.
How?
How does it reduce?
It prevents epithelial ovarian tumors of ovary, which can
starts from the
fallopian tubes, ma'am. Femoral end of the fallopian tubes.
Yes, it's been seen that most of the epithelial tumors, they can start from the tubes and then spread to the ovaries.
Ovaries, yes, ma'am.
All right, so now we can come back. So this is about the initial, and what else are you going to explain when we say she's going to undergo hysterectomy? So, okay, you've talked about menstruation, you've talked about childbirth, you've talked about ovaries. What else are you going to talk about?
Ma'am, we will talk about the risks of undergoing any operative procedure. That is risk of anesthesia, risk of injury to adjacent organs like bowel, bladder, ureter, and major vessels.
Specific hysterectomy?
Ma'am, risk of injury to adjacent structures, ma'am.
Right. And urinary symptoms, very important.
Urinary symptoms, risk of hemorrhage, or risk of requirement of blood transfusion in case she if there is more blood loss. We will counsel the patient about the risk of infection, pelvic abscess, about prolonged hospital stay.
But she's interested in her future sexual life. What will happen?
Ma'am?
Shortening of vaginal length, ma'am.
Why would they occur? No, I'm to say, if she will, she is concerned about whether it's going to affect her future sexual life or not. What are you tell her about?
No, ma'am, it will not affect.
So you should tell her that it will not affect. So question will have many questions. You should have very clear answers to that. That is what we want you to know, right?
Yes, ma'am.
All right. Now, so this is all about the hysterectomy part you've said. Now, about specific routes. How are you going to counsel? So we will start with the vaginal route. Advantages?
Ma'am, by vaginal route, the healing, there will be no incision and the healing will be better and sooner.
No incision on the abdomen, right?
On the abdomen, yes, ma'am.
To be an incision in the vagina. Okay?
Yes, ma'am.
All right. And faster recovery?
Yes, ma'am, faster recovery.
All right.
And pain will be comparatively less as there is no incision on the abdomen. So,
is the pain less in patients who have non-descent hysterectomy? Have you seen patients who have hysterectomy?
Yes, ma'am. It is less than open hysterectomy.
You know, the immediate period, the patient has more pain because you apply traction onto the ligaments, no? So in the first 24 hours, the pain is more, but of course, faster recovery later on, right? Because you tug at the ligaments, no? So the first 24 hours, the patient has quite a bit of pain. Okay, that's fine. And what are the disadvantages of vaginal?
Ma'am, it is difficult to perform and it requires more expertise. And
you are targeting the doctors, not the patient.
So no obvious, problem there could be, except that from your side, you know that person has to be experienced, right?
Yes, ma'am.
Rest all should be okay. I think it has all other side effects which others would have.
All
Okay.
the bladder and the rectal injuries are all more
In open, ma'am.
discernible.
Ma'am, in vaginal hysterectomy.
No, it all depends on the expertise of the. Let's put it like that. So if you compare vaginal hysterectomy non-descent versus hysterectomy for prolapse, then the injuries are
definitely
not otherwise. Not otherwise. It is quite a safe. All right. Now let's come to the abdominal versus laparoscopy. So abdominal would be open or conventional, or it would be laparoscopy. So what are you going to tell her?
Ma'am, in abdominal hysterectomy, the scarred site would be more. There would be that would be associated with pain for a longer period of time. The healing is will take a bit. The healing is a bit delayed.
Healing
as
is not
compared to
delayed, but the
laparoscopy.
recovery time would be more.
Recovery time would be more.
It will take a longer to recover, right?
Yes, ma'am. Yes, ma'am.
And more chances of surgical site infection. Right?
Yes, ma'am. Yes, ma'am.
So that is what it would. And with laparoscopy?
With laparoscopy, there is a lesser pain, less pain, less blood loss, less hospital stay, and the skin incisions are also very small, so it has faster recovery.
And
cosmetic advantage also.
Any disadvantage?
The risk of injury to bowel and ureter are more in.
So and the anesthesia part, it has to be done under.
Okay, ma'am.
So when you talk about vaginal versus laparoscopy, vaginal can be done under regional, which is referred, and that has to be done under GA, right?
Yeah, yes, ma'am.
You're going to put it to the patient and let the patient pick up whatever she wants. Okay.
Yes, ma'am.
So you've done a hysterectomy for her, right? And
yes,
she goes home. So what advice are you going to give when you're going to discharge her?
Ma'am, we will advise her not to. We will advise her proper rest. We will advise.
Hold on. What is proper rest?
Ma'am, not to bend, not to lift heavy weights for 3 months. We will advise her not
to. Hold on. You can't just go on and on. You have to be very clear when you give instructions to the patient. That is where we go wrong, no? So we just tell them, we presume they are knowing it. So she's going
to avoid strenuous activities.
Yes. So she will, no. Yeah. So you can ask her to resume her. I'm saying talk positive, no?
Yes, ma'am.
Yes, ma'am.
First tell her what she can do. No?
She can resume day-to-day activities, but she has to avoid strenuous activities, and she has to avoid exercise and heavy weightlifting.
Going up and down the stairs. Going up and down the stairs. That you can, right? So yes, she can resume her routine activity, but of course you have to rest. For how many weeks she should be resting?
Ma'am, depends upon the route of the surgery.
Right. So
major operation, at least 3 to 4 weeks, she should go a little slow, not total rest, but
yes,
a little.
Right, so that is fine. So she'll take about, different people will take. So normally within 6 weeks, we should say she should be able to resume her all routine activities. Okay.
All normal.
So what else are you going to tell her? What other advice?
No sexual intercourse for 3 weeks.
Why 3 weeks?
3 months, ma'am.
No, why 3 months? You want to examine her, no? After 6 weeks, you will call her for a follow-up. You would want to do a PS examination. You want to look at the suture line, right?
Yes, ma'am.
Normally 3 months is okay if you tell her, but once the wound heals, that is what we are waiting for, no? We want that to take place, and after that she can resume. So there is no hard and fast rule, but generally about, even we see them after 6 weeks, we can still see some sutures there, no? Normally,
yes, ma'am.
So I'm saying we do not have any, I'm not aware of any strict recommendations, but normally it takes them about 2 months or so and resume, right? Fine. Okay. What else are you going to tell her? She's 44 years of age. I'm giving you a clue.
That she has to take her supplements, calcium and vitamin supplements regularly.
Yes.
As her BMI, as her bone mass index could decrease. And
we've kept the.
All right. Then what else do you want her to tell? What is your take on antibiotics? I'm saying if a patient is undergoing hysterectomy, how would you what will be your antibiotic protocol for your patient?
Ma'am, for 5 days, pre-operatively, one dose of antibiotics is given, and post that for 5 days, IV injectables are injectable antibiotics are given continuously.
You mean to say you want to keep all the patients in the hospital for 5 days?
No, ma'am, for 3 days.
No, but why do you want to give her? I have to say it is purely elective. So why do you want to give her antibiotics? Do you think a single dose of prophylactic antibiotic would suffice?
Yes, ma'am.
नहीं आप इतनी मतलब yes इतने लो टोन में क्यों कह रहे हैं जैसे कि आप बिल्कुल एग्री नहीं कर रहे हैं जैसे मैं बोल रही हूँ.
Yes, ma'am.
You just need to give her a single. What she has is a clean contaminated wound है ना, vagina के साथ communication है, तो बस single dose is sufficient. So when you give prophylactic antibiotic, तो क्या antibiotic recommended है और क्या dose में recommended है और कब देना?
Third generation cephalosporins are recommended.
No, I disagree.
Ma'am, broad spectrum antibiotics.
Broad spectrum, but you need not give third generation. Why am I asking you not to give third generation? You can give anything, but we have lower generation antibiotics also, which are recommended by ICMR, which are recommended by various societies. So वो evidence based है. So which antibiotic is actually recommended?
Cefazolin is recommended.
Cefazolin is recommended. Cefuroxime is also recommended.
Cefuroxime, yes, ma'am.
Okay. And you can give a third generation, but there is no need to give third generation. That is it. And even augmentin can be given. Someone had written augmentin. So all these are broad based. So what dose will you give, and at what time would you give?
Ma'am, within 1 hour of surgery, we will start injectable antibiotics within 1 hour of surgery. The first dose that has to be given.
1 hour of the incision, giving the incision.
Yes,
prior to the incision, 15 minutes to 60 minutes, 15 to 60 minutes. Within that time, you must give it. Okay?
Yes, ma'am.
So that is what is to be done. Okay, and then there are no antibiotics are to be given. Why do you think that no antibiotics are to be given? What is the harm of giving antibiotics for longer period?
Gastroenteritis.
Yeah, one is the gastroenteritis.
GI upset. It can hamper the normal flora.
Absolutely, it can hamper the normal flora and it can lead on to unnecessary
antibiotic resistance.
So that is why we should not give antibiotics. Okay, over to you, Dr. Sunita. Please ask more questions.
I think we've done it. Now, what else she should see? I mean, what she should be careful about in the future?
So even the danger signs, what do we tell her? Let them tell the danger signs. When we are discharging her, when will you call her for follow-up?
Now we will say ask her for follow-up after 6 weeks of the surgery.
And would you like to...
in case she has any leaking, bleeding per vaginum or any wound dehiscence, any soakage of discharge, any wound discharge.
What else?
Any bladder complaints like incontinence, UTI, or a history of constipation.
Anything else?
Fever.
Yes. So fever and not feeling unwell. Sometimes they might go into sepsis and without, especially if you do laparoscopy, then any pain abdomen. You must tell them all these findings in which case they should return back to the
hospital. Yes, ma'am.
When she comes for follow-up, what all are you going to see?
Ma'am, when we will look for the whole head-to-toe examination of the patient first. We will
hold on. पहले symptoms नहीं पूछेंगे कुछ. सीधा head करेंगे patient को.
Ma'am, if she has any complaints regarding the suture line or pain, abdomen, fever, any complaints that she has, then we will have a proper general physical examination of the patient. On per abdomen examination, we will look for the wound healing, if the sutures have resolved or not, if there is any discharge or not, if there is erythema or swelling of the wound.
It's fine.
And
so you look at the stitch line. What else do you look at?
Ma'am, we will do per speculum and per vaginum examination also to look at the vault, if the sutures have healed or not, if there is any bleeding, or if there is any marked signs of infection.
Per vaginum क्यों करेंगे?
To see the vault, ma'am, to see the vault line.
So there could be some cellulitis at that place.
Cellulitis, yes, ma'am.
There could be any infection, so that is why you must do a PB exam. और क्या करेंगे आप examination के time पे? There's something which is very important which you need to review at this stage.
Ma'am, histopathology report.
हाँ, ये तो आप बिल्कुल नहीं भूल सकते because आपके patient को hyperplasia भी था ना?
Yes, ma'am.
Any patient whom you look up in the post-operative follow-up, please make sure that you look at the histopathology.
Yes, ma'am.
And you jot it down and re-counsel the patient based on that. Okay?
Yes, ma'am.
और उसके supplements उनको वापस से शुरू करेंगे patient को. Right?
Yes, ma'am.
और regular follow-up के लिए counsel करेंगे.
Yes, ma'am.
Right? And she has high BMI also, तो 6 महीने के बाद उसको बोलेंगे BMI.
Weight reduction का भी exercise.
Holistic care of the patient होना चाहिए. नहीं?
Yes, ma'am.
Dr.
And for
Sunita, your
breast and
final words.
later on. That's it. And to be sort of vigilant about breast and ovarian problems. That is all. To be relaxed that the uterus is out and all the problems gone.
No, ma'am. She will have to check for any breast abnormalities. Any, she will have to undergo. Ma'am, we will advise her to undergo mammography.
Mammography.
Yeah.
She must have a mammography as well. Yes.
Yes, ma'am.
So about all the kind of preventive, care, you must counsel the patient and not miss out on this opportunity, right?
Okay. Yes, ma'am.
We are over with the time. Thank you so much.
It was a nice session, ma'am. Thank you.
Thank you, ma'am.
Well presented and we enjoyed it. Okay, thank you, Dr. Sunita.
Thank you,
Thank you,
ma'am.
Thank you, Dr. Muni. Thank you.
Thank you, respected faculties, for the great insight on various aspects of AUB, ma'am. We all participants, we have gained a lot during the discussions for sure. Now I would like to proceed further and gynecology. Dr. Ram Manohar Lohia Hospital, New Delhi. I want to request sir to continue further, sir.
Patient was apparently all right 1 month back. Then she complained of lower abdominal distension, insidious in onset, has gradually progressed over to the past 1 month, not associated with food intake. Pain in abdomen since 1 month. It was dull aching in nature, intermittent 3 to 4 times in a week, lasting for 15 to 20 minutes. Localized mainly to lower abdomen, aggravated on daily routine, on doing routine daily activities, not relieved with oral medications. Pain was non-radiating. No history of abnormal uterine bleeding, no history of discharge per vagina, no history of nausea, vomiting, no history of feeling of fullness after meals, no history of burning micturition, increase in urinary frequency and urinary retention, no history of difficulty in passage of stools, no history of significant weight loss and appetite, no history of swelling of feet and shortness of breath, no history of any evening rise of temperature. Menstrual history, menarche at the age of 14 years. Last menstrual period was 24th of April 2023. Her cycles were of 3 to 4 days, came at a regular intervals of 28 to 30 days, with an average flow not associated with passage of clots, using 2 to 3 pads per day with no dysmenorrhea. She was unmarried, not sexually active. Past history, not a known case of diabetes mellitus, hypertension, thyroid disorder, or tuberculosis. No history of any previous abdominal surgeries. No history of blood transfusion in recent past. Family history, no history of hypertension, diabetes mellitus, asthma. No history of any malignancies in family. Mother attained menopause at the age of 50 years. Personal history, she had a mixed diet, sleep was adequate, bowel and bladder habits normal, regular, no history of any addiction, no history of any allergic disorder. On general physical examination, patient was conscious, oriented to time, place, and person, average build, general condition was fair, height 155 centimeter, weight 52 kgs, BMI of 21.3, pallor was present, no cyanosis, no icterus, no palpable lymph nodes, no pedal edema. On examination, thyroid gland was normal. On bilateral breast examination, it was soft. Nipple areolar complex was normal. No discharge, no palpable lump was felt. Patient was afebrile. Pulse was 84 beats per minute, regular in rhythm, high volume, normal in character. BP was 110 by 80, taken from left hand in sitting position. Respiratory rate was 14 per minute. And on systemic examination, cardiovascular system S1, S2 was heard. No murmurs were heard. Respiratory system, normal vesicular sounds were heard. No adventitious sound present. No neurological defects. Abdominal examination. On inspection, abdomen was distended just above the level of umbilicus. Umbilicus was central and inverted. No scar marks, dilated veins, visible pulsations, no skin changes. Hernial orifices were intact on cuffing. All quadrants of abdomen were moving equally with respiration. On palpation, 26 to 28 weeks size abdominopelvic form to cystic mass felt, extending from pelvis up to just above the umbilicus. It surface was smooth, well-defined margins. Lower margins were not felt. It was non-tender, restricted side-to-side mobility, no local rise in temperature, no other organs palpated due to mass. On percussion, dull note over the mass and flanks, no shifting dullness. On auscultation, bowel sounds were heard. Local examination. External genitalia was normal. Perspective examination was not done. Pervaginal was not done. On rectal examination, rectal mucosa was free. Firm cystic mass felt. No nodularity was felt. So my case summary was Miss XYZ, 28 years old, unmarried female with 26 to 28 weeks size, abdominopelvic mass with lower abdominal pain.
Okay. Nikhil, can you come to your history part, the initial part?
Yes. Yes, sir.
So now you have taken a lot of, positive histories and negative histories.
Yes,
so,
sir.
Can you just, with this setting,
Yes, sir.
why have you taken, history of abnormal uterine bleeding, discharge per vaginum, nausea, vomiting, feeling of fullness? Any correlation that you have taken?
Okay, so history of abnormal uterine bleeding was taken because in granulosa cell tumor, as it's a hyperestrogenic tumor, so it is associated with abnormal uterine bleeding. In case of tubo-ovarian mass, there is discharge per vaginum. Then nausea and vomiting may be associated in certain conditions of ovarian malignancy. No history of feeling of fullness after meals is taken to rule out any GI cause. If the tumor is pressing over in the POD and pressing over the bladder, then there may be symptoms like increased urinary frequency or urinary retention, which may lead to a burning micturition also. And if the tumor is pressing over the rectum, then it may lead to constipation. We take no history of significant weight loss and appetite to rule out TB also and malignancy also. And if the tumor is pressing on the inferior vena cava, there may be swelling of feet, and if it's a huge tumor, it may press upon the diaphragm, and there would be shortness of breath in the patient. And no history of any evening rise of temperature was taken to rule out tuberculosis again.
Okay. Now, the first thing you told was no history of abnormal uterine bleeding with granulosa cell tumor. So do you think that it is common at this age group, in this age group?
No, sir, not in this age group.
Do you know about the types of granulosa cell tumor?
So juvenile and
yeah.
adult type of
Adult type,
granulosa.
yeah. So juvenile can happen at this age group?
So, yes, sir.
Yeah. So it can happen. So you usually, on histology, we come to know about there are two types of, so usually the juvenile granulosa cell tumors present at an earlier stage. So that's why I was asking that, because she's a, young unmarried girl.
Yes, sir.
And in addition to what you told about nausea, vomiting, and feeling of fullness after meals,
Yes, sir.
it is not always about GI. It may also tell you about the, if, for example, if she had any of the genital malignancies, sometimes
Yes,
spread to the omentum, or having lots of ascites can also
Yes,
cause all these things. And early satiety is a symptom of ovarian cancer.
Ovarian, yes, sir.
The main symptom. So I think, when it comes to presenting the symptoms, first rule out all the gynecological part, and then the GI part. The GI part would be more of, probably, which is not mentioned, is having history of Malina.
Yes,
that
sir.
would come more into the GI part.
Okay, sir.
If this lady had, the same findings, and she had a significant Malina, or, bleeding per rectum, what you would have thought about?
So maybe a colorectal
Yeah.
origin.
Yeah, a colorectal cancer with probably,
Yes, sir.
metastatizing to an adnexal mass.
Yes, sir.
Okay. So now can you come to the summary part?
Yes, sir.
Okay. So what is your differential in this patient? Looking at your clinical findings, what do you think? It is uterine or ovarian, or what? Can you
yes,
can you
sir.
place in DDs? That ovary more than uterus, or non-gynecological more than gynecological, anything.
So on clinical,
yeah.
So on clinical examination, there was a group felt between the uterus and the adnexal mass. That's why it was an ovarian origin. And sir, with the mobility on pervaginal, no, not on pervaginal. Hingorani sign it tells it was.
So why I'm telling you this is because you cannot do that sign in this patient, because you have not done a pervaginal examination in this patient.
Yes, sir.
So,
Yes,
if
sir.
you have that expertise of, doing it via the per rectal examination, knowing, feeling even the fundus of the uterus and trying to feel, you can do the same on PR, but probably, that would come with time and experience. So,
Yes, sir.
as per your findings, what do you think? Ovary, uterus, non-gynecological, what?
So most probably it's an ovarian mass only.
Okay. And what supports that diagnosis in your history and your clinical examination?
So so lower margins were not felt, which says that it's rising from the pelvis.
Pelvis. Okay. So
Yes,
you
sir.
feel, gynecological more than, non-gynecological, probably because such a big extent of mass getting from appendix or sigmoid of 28-30 weeks, usually you don't get such a big mass. And when you get other non-gynecological conditions, there you can actually feel the space. You can get into the pelvis. Here you are not able to get into the pelvis. So so gynecological more than non-gynecological. And in gynecological, what is your first between uterus and ovary? Because you are not done the Hingorani sign, which you were telling, because pervaginal examination is not done in this patient. But then what other factors do you consider? History, age, anything else?
So history, age, low menstrual abnormality also, sir.
Okay, so there is no menstrual abnormality. So what it would be, in what favor, ovary or uterine?
Ovarian, sir.
Ovarian more than uterine. Okay.
Yes, sir.
Okay. So what would be your differential diagnosis in this patient? If
So it could be benign and it could be malignant.
Okay.
So it could be a cyst, functional cyst or corpus luteum cyst. It could be a tubo-ovarian mass.
Such a large one? Functional
no,
can
sir,
be,
not,
yeah,
no,
30 weeks.
Yes, sir, not such a huge.
Yeah.
Could be.
So what would be the
Then
more
sir,
commoner ones? Because it
para-ovarian
is,
cyst.
yeah, because you're telling firm to cystic,
Yes,
So
sir.
yeah, para-ovarian cyst, okay, accepted.
So then cyst adenoma,
Okay.
tubo-ovarian abscess. So
Okay. But do you have a
peritoneal
history of vaginal discharge or fever in this patient?
no vaginal discharge, no history of fever, sir. So then a mesenteric cyst, sir.
Okay, no, first complete the gynecological part.
Okay. So then sir, in malignancies, germ cell tumors, epithelial ovarian tumor.
Okay. More
These
than
are the
epithelial?
most. So germ cell.
I think borderline. Yeah.
Borderline, yes sir. Yes sir. Borderline.
Yeah. Borderline. Okay. So in this age group, what would be more common, epithelial or borderline?
So borderline is more common at the age of 40 years and above. So
and epithelial?
So epithelial can present at this age. So
is it?
Mucinous one can present. So yeah, serous one presents late. So
no, I think epithelial carcinomas present much more later, so they won't come into very early signs. So I think when you speak of the ovarian masses in this age group, definitely germ cell or even sex cord stromal tumors like juvenile granulosa cell tumor, which you told in the start, would be your initial DDs. Then epithelial, and that would be only by exclusion in frozen or in the final histopathology report. Okay. And what about the non-gynecological causes?
Non-gynecological causes include mesenteric cyst,
okay,
appendicular lump, peritoneal inclusion cyst.
30 weeks appendicular lump?
No sir, no sir, not such a huge mass.
Okay.
Subserous fibroids. So
yeah, that would come in
non-gynecological, so
yeah.
non-gynecological.
Yeah, but because I'm not telling that any reason for it,
Yes,
that, if anything on your palpation, which says that, yeah, this is not a fibroid, rather than, so certain fibroids can present because you have
Yes,
written
sir.
home to cystic on the field.
Yes, sir. Yes, sir.
So up till there is degeneration of this fibroid, usually fibroids would be quite solid on that front. But you have written clear cut that it was a firm to cystic mass which was felt.
Yes, sir. So then pelvic kidney could present, but not not such huge.
28,
These
30.
are the difference.
No,
These are
I'm
the
asking,
non-gynecological.
yeah. I'm asking only about this patient, not.
Okay, so then mesenteric cyst would most probably present like this. Matlab such a huge.
Okay. I think peritoneal inclusion cyst can present.
Peritoneal inclusion. Yes, sir.
Yeah.
Yes, sir.
So all the other DDs, which are like, bladder diverticulum, sigmoid diverticulum, and, appendix, mucocele, and all those things. So
Yes, sir.
those are DDs as per the textbook, but you also have to consider for this patient, you have written a 28 to 30 week size.
Yes, sir.
Whether
26,
such large diverticuli and everything without patient having, any imminent signs of, rupture in this. So it's very, because this is a stable patient as per whatever you have done the clinical examination. The blood pressure is normal, the heart rate is normal, she's comfortable and everything.
Yes, sir. Yes, sir.
Okay, so what would be your first investigation of choice in this patient?
So transvaginal ultrasound.
Transvaginal ultrasound?
Sorry, ultrasound, sir. Ultrasound. TS.
Because you have not done the PV also, no?
Yes, sir. Yes, sir. Sorry.
Yeah. Okay. So you will do a trans-abdominal ultrasound.
Yes, sir.
So what are the features you would look for?
So we will look for the iota, basically, where we will so we will look for multilocularity, if there are any solid areas, if there are any intra-abdominal mets.
This is is this called something in iota? Like simple rules.
Sir, there are B rules and M rules in iota. Sir.
Okay. So what are the B rules?
So B rules is a unilocular cyst B1. Then B2 is solid areas with a diameter less than 7 mm. B3 is acoustic shadows. B4 is a smooth multilocular tumor with a largest diameter less than 100 mm, and B5 is color score of 0.
Color
No
score of
increase.
1, I think so.
One. Yes, sir.
Yeah.
Right. One.
Okay.
And then, sir, M rules include M1 includes irregular solid tumors, M2 include ascites, M3 at least 4 papillary projections, then M4 irregular solid tumor of greatest diameter more than 100 mm, and M5 very strong blood flow or color score of 4.
Okay. Okay. So, any other mode, any other investigation you would like to do? Ultrasound is the first thing. Okay.
Yes, sir.
So, and any other primary investigation you want to do in this patient? If suppose your ultrasound confirms that, yeah, it is an ovarian mass. So
Yes,
any
sir.
other investigation you want to,
So tumor markers we will then do.
Okay. Which one?
So CA 125,
Okay.
CA 19.9, LDH, alpha fetoprotein,
Okay.
CEA,
Okay.
AFP, beta HCG. So
Okay. Can you tell me the significance of each of this? Like,
yes,
CA 125, okay. Probably suppose, can you tell me the normal value of CA 125?
0 to 35. So
okay. And what is the units?
So IU per ml. So
IU per ml. Okay. I think Dr. Seema has also joined. So
yeah, hi, Dr. Modi. Hi, everyone. I'm so
Hi.
sorry for delaying.
Yeah.
We will go on. Can you just tell me
Okay.
the age of this patient just before I start the thing?
Yeah, I think Nikhil, can you tell the summary of this patient?
Yes. Ma'am, this is my patient is XYZ, 28 years old, unmarried female with 26 to 28 week size, abdominal pelvic mass with lower abdominal pain.
Okay. Please go on now.
Okay.
Yeah. So you were mentioning the tumor markers. So So let's start with that only. So which all tumor markers? C125, CEA, right? You said that.
Yes, ma'am. Yes, ma'am.
And others?
Ma'am, CA 19.9 alpha fetoprotein, then LDH, beta HCG.
Okay.
Okay.
This will be done, ma'am.
Any other imaging and other investigations, please?
Ma'am, CT scan is usually done to rule out any meds, and MRI is done when the ultrasound is inconclusive of the origin of the mass. Then we'll advise for MRI.
So in this patient, which one will you do?
So, ma'am, first we'll advise for an ultrasound only, ma'am.
So you advise an ultrasound, and you found there were 2 M rules, right?
Yes, ma'am.
So
yes,
next, and you advise for the tumor markers. Then what? Any other imaging which you would like to do?
Then, ma'am, if 2 of M rules are present, then we'll advise for CT scan, ma'am.
What kind of what you would cover in the CT scan?
So they tells about the peritoneal implants or any lymphadenopathy if present.
No, I'm asking what you would advise in CT, CT pelvis, CT, do you want to do abdomen pelvis, or you also
abdomen pelvis, CT abdomen pelvis.
Okay.
Yes, sir. Contrast enhanced.
Okay, contrast enhanced abdomen plus pelvis. Okay.
Yes, sir.
Okay.
She's just 28 years old. So what is your next plan?
Ma'am, first we will investigate her properly.
Means what all investigations?
Ma'am, routine blood investigations, ultrasound, tumor markers. We have done the tumor markers, ma'am. Then it was CA 19.9 was raised. It was 1200. So, and on ultrasound, there was a large cystic pelvic mass with multiple internal septations of size 21 into 15 into 16 centimeter with no solid component in the cyst.
Okay.
So most probably based on the tumor markers and imaging, it's going for a mucinous one. And then we'll also do a Roma scoring for this patient.
Why would you like to do a Roma scoring for this patient?
Ma'am, to know the risk of malignancy in this case, ma'am.
So her CA120, CA90, she has a large 26 to 28 week size abdominal pelvic mass. Her tumor marker is raised. The imaging is showing a proper significant adnexal mass. So what
Yes,
additional benefit would you get by doing a Roma scoring for this patient? So
It
first,
will
what
only,
is the differential diagnosis? Okay, let's start this way. It will be easy for you to answer. What do you think with this report? What is your differential diagnosis?
ma'am, it could be a mucinous cystadenoma, borderline tumor, or mucinous cystadenocarcinoma.
So, okay, she could be an epithelial malignancy, probably mucinous, right?
Yes, ma'am.
Epithelial marked tumor, maybe borderline or maybe malignant, right? You are right. Anything else she could be? Anything else which comes to your mind with the above reports and above imaging and everything? See, she's a large mass. Okay, she's a
Yes, ma'am.
large mass. And ultrasound per se, only ultrasound you may be missing some areas, some solid areas or something, which you could
Okay,
be
ma'am.
this younger. So with this LDH raised, here 19.9 raised, a germ cell tumor still, comes in our differential diagnosis, right?
Yes, ma'am.
So with these two differential diagnoses in your mind, would you still like to do Roma scoring for her?
No, ma'am.
Right. So it's not required to do Roma. Dr. Modi, do you agree with that discussion?
Yeah, of course. Yeah. No role of Roma in this patient. So, Nikhil, can you tell where would you actually do a Roma score?
So in patients with epithelial ovarian cancer, we advise for Roma score.
No, I don't. If you know that it is epithelial, but will you require doing Roma? Roma
Suspected,
is, where
Is
you are
Roma
confused. I think
please
so.
let us know what is Roma index. What is Roma index and how does it help? Let's see that first.
Ma'am, it includes CA125 values, HE4 value, and premenopausal or postmenopausal status. Then we feed it on a computer, and then the value comes. If it is less than 1.3 in a premenopausal female, then there is no risk of malignancy. And in a postmenopausal, 2.27. Then there is no
First
risk.
of all, when you explain, Nikhil, there's no index which can tell you that there is no risk of malignancy. The probability will be low. Okay.
Yes, ma'am. Yes, ma'am.
It's more likely to be benign. It should be expressed like that. That's one thing. And second thing, as Dr. Modi said, the Roma index will be useful in younger women when your differential diagnosis, your C125 is raised, but since they're younger women and the specificity of C125 is lower in this particular age group, then you take the benefit of having HE4, which is a more specific marker, and use this computerized algorithm to differentiate it with other benign masses. Okay?
Okay.
Want to decide your further management, isn't it? So
Yes,
in
ma'am.
this situation where you are in, where your CA19.9 is already so much raised, you
Yes,
have a
ma'am.
large adnexal mass, multiseptated, maybe cystic, looks like cystic, but could be some borderline areas or something missing. So then you would, what is your plan of management now?
So any other investigation, any imaging you want to do, young girl with such a high CA 19.9, do you want to rule out anything?
So pancreatic cancer, we must rule out.
Yeah, but which imaging you will do, imaging and any other additional investigations you want to do? Any scopy or something, you want to...
Colonoscopy, sir, or upper GI endoscopy, sir.
Yeah, upper and lower GI endoscopy.
Upper and lower GI endoscopy.
Yeah.
And breast examination for her as well,
Yes,
breast. So if you, at this age of hers, in case there's any doubt, what imaging will you advise for her breast?
As she's 28 years, ultrasound would be advised because the breast is dense in this young age group.
Right, you are. So suppose her endoscopies are normal, right? So what is your next plan? So when you say your differential diagnosis, Nikhil, yes, definitely it was prudent to say that still you cannot rule out any metastatic mass in the ovary, right?
Yes, ma'am.
Yeah. So go ahead, please.
So have you done any, okay, you have calculated the RMI score for this.
RMI score. Yes, sir.
Okay.
So RMI score, the fallacy is quite visible that
Yeah.
it is meant on based on CA125 only, right? And this particular age group, CA125 is not so specific,
Non-specific.
Yes,
right?
ma'am.
And that
Yes,
is
ma'am.
why RMI score is non-conclusive. It won't help you in this particular scenario. CA 19.9 is not given a consideration for this RMI score, and that is the fallacy. Okay.
Okay, ma'am.
So, before proceeding to the plan on the, management in this patient, you have done a upper GI, lower GI, So do you want to know about the status of other organs and, anything else you want to know before you make a final plan of, that whether you want to go for, surgery, what kind of surgery, and, how would you counsel then? Anything more in imaging you want to do?
So chest X-ray also will advise. So PET scan, yes.
PET
And
scan
then
is optional. Yeah, that's
Optional,
optional.
yes.
It's not mandatory in this patient.
Nikhil, there's one more condition that you are missing. That do you think she could be endometriosis in some way? Do you think so?
Yes, it could be endometrioma, ma'am.
Endometriosis is frequently
But,
seen to be associated with false positive markers.
But there is
LDH
no
is also raised.
ma'am, there's no history of dysmenorrhea, ma'am, in this patient.
Okay.
Or
That's a point.
pain during
Okay.
or pain during passing urine or defecation, ma'am, or yes, ma'am. These are the histories that are missing.
Okay. Any blood test, any tumor marker which can help you, say endometriosis versus maybe, some other ovarian pathology, you spoke about it earlier.
So CA125 is raised, so.
No, but CA125 is non-specific. Anything which negates the effect of CA125. That's where the concept of Roma came in.
HE4, sir.
HE4 sometimes can help you in endometrioma versus non-endometrioma conditions, but still that's very the proper values have not been set in for that. Of course, when it is too high, it goes more in favor of malignancy, but it is more in the epithelial components than in other malignancies. Okay. So from all of this, what is your, further plan of action for this patient? Considering the age and everything, what would be counsel the patient, the relatives? She's unmarried. So what would you counsel the parents, and what would be your surgical plan for her?
So we'll advise for fertility preserving surgery, sir, which would be a unilateral salping oophorectomy.
Okay, I think first you will plan for a staging laparotomy because she is not.
Still too early to say that.
Yeah.
That I will do a unilateral salpingophractomy. You have not even yet opened her. So plan that you want to do a surgery and then the mode of surgery, and then you decide what will be the extent of surgery. Go systematically. Okay, Nikhil?
Yes, ma'am.
So can you tell in order, like how Dr. Seema told you, the surgery, the mode of surgery, and the extent, so how would it be, so first staging laparotomy, which I'm telling you that, you are, and what would be the mode, for a 28 to 30 week mass, what would you prefer,
we give a
open, what would you, with CA99 of more than 1200, what would you be on?
So open route only, a large vertical incision over the abdomen to open.
Okay.
Supraumbilical incision.
Okay. Okay. So, okay, you opened her up and everything, and you find that, there is only one ovarian mass. The uterus looks normal to you. The other ovary looks normal to you. You have some deposits on omentum.
Yes,
what would be your, further plan of action in this patient?
So
Like,
after first during the opening, we'll take the peritoneal washings and we'll send for the cytological examination.
So how do you take over cytology? Just tell us.
Ma'am, if there is presence of ascites, we take 20 to 30 ml of the ascitic fluid and send for cytological examination. If there is no free fluid, we'll wash it with normal saline, and then we'll take 50 to 100 ml of the normal saline and send for cytological examination.
Okay, go on.
Then we'll examine, we'll start from the cecum and then we'll move cephalad, and then we'll examine the ascending colon, the transverse colon, then the descending colon, the sigmoid, everything we'll examine. We'll look for any peritoneal mets. We'll take the peritoneal biopsies. Then we'll look for if there is any mets in the omentum. If they are present, we can do a infracolic omentectomy.
No.
And
in this patient, okay, you have taken the cytology and everything. What would be the next first thing which you would do? You're not aware of the diagnosis.
So we'll take out the specimen and send for frozen section. So.
Okay. So you've sent the specimen for frozen section. Okay, it has come to be, borderline mucinous tumor. What next? Okay, and now you would have definitely counseled the parents that you would inform them intraoperatively about the frozen section, because they would be worried about the fertility of the girl. So what would be your how would you counsel them now? You see deposits on the omentum. So what would you be counseling them?
So I would counsel them that this is a frozen section report, so it is a temporary report only. We'll do the unilateral fertility preserving unilateral oophorectomy, and then infracolic omentectomy if there are omental mets, and we'll wait for the final.
If there are omental mets, you will take infracolic.
If there's omentum mets.
If there are omental deposits, if you see, will you take infracolic or supracolic?
And that's another thing here. It's here itself you have to consider, as he's giving you a hint continuously that there's an omental disease present. So do you still think it could be a borderline? So in other words, you should explain and try and understand what are the fallacies of frozen section, especially in cases of mucinous tumors. Can you explain what are the fallacies which you should explain to the relatives and the patient beforehand, before you take them for the session?
The frozen section reports has a lower accuracy report, so we must wait for the final histopathological report, which comes after
not
7.
Not in all the cancers. What is specific to mucinous tumors? There's something which is very specific to mucinous tumors, and that should be considered always while you take into account the report of frozen section in mucinous tumors. See, mucinous sections are very huge tumors, right?
We'll inform about the appendix, ma'am. Okay, we have to remove appendix also.
No, you have visualized the appendix, suppose it is normal. Okay.
Yes, ma'am.
So
yes,
now the thing is that the mucinous tumors are massive tumors, like the large tumors, 26, 28 week size. So, and in the same tumor, within the same tumor, you have the areas of normal, benign, borderline, and even the malignant invasive counterparts. They all exist within the same tumor. So when you take the sections, you're taking sections little far away, like 5 millimeter, 1 centimeter away. Then in those situations, you will miss those areas of invasion. So this is a major fallacy of frozen section, which holds true in patients with mucinous tumors. Similar thing does not exist with others. Is that clear to you?
Yes,
so
ma'am.
frozen
Yes,
section is totally reliable when it comes to mucinous tumors.
Okay.
So,
Okay.
yeah, Nikhil. So that you have to remember, among all the ovarian tumors, mucinous are the most heterogeneous type of tumor. And most of the times, when there is an upgrade, it happens mostly with the mucinous tumors. High-grade serous, germ cell are much more, they are more towards accuracy in frozen section also. But as Dr. Seema told you,